Вітання кожному, хто у важкий час підтримує Україну. Щиро дякую тим, хто не втомлюється боротися на своєму фронті заради перемоги України. Величезна вдячність усім, хто науковою допитливістю творить нове життя медичної науки. Ми раді вітати вас на 12-му міжнародному медико-фармацевтичному форумі студентів та молодих вчених BIMCO-2025. We are delighted to welcome you at Bukovinian International Medical and Pharmaceutical Congress of Students and Young Scientists BIMCO-2025. Ми живемо у стані війни уже 11 років. Повномасштабне вторгнення змусило нас консолідувати свої сили, об'єднатися і стати на захист своєї землі. На жаль, не всі повернуться із поля бою. Не кожна дитина дочекається батька, не кожна мати обійме свого сину. Кривава ціна за свободу. Ми просимо вшанувати хвилиною мовчання усіх, хто загинув за наше з вами життя. Please commemorate all the victims of this horrible war with a moment of silence. Дякую. Thank you. Наша світла пам'ять, наша безмежна вдячність і наша любов служитимуть орієнтиром для душ постраждалих у цій війні, для повернення на українську землю новим поколінням. Тож пам'ятаймо і тримаймо стрій, щоб бути частиною великої України. І свідченням нашої беззаперечної віри у краще є сьогоднішня наша зустріч. Буковинський державний медичний університет вже в 12-те радо зустрічає молодих науковців з усієї України та за її межами. Австрія, Албанія, Азербайджан, Болгарія, Канада, Хорватія, Великобританія, Грузія, Індія, Індонезія, Киргизстан, Латвія, Литва, Молдова, Німеччина, Пакистан, Польща, Португалія, Румунія, Іспанія, Швейцарія, США та багато інших з великим задоволенням долучаються до масштабної події у науковому світі. А ми щиро тішимося, що наша боротьба на усіх фронтах продовжується. Отож, 12-й міжнародний медико-фармацевтичний конгрес студентів і молодих вчених оголошується відкритим. 12th Bukovinian International Medical and Pharmaceutical Congress of Students and Young Scientists is declared open.
Ще не вмерла України ні слава, ні воля. Ще нам, браття українці, усміхнеться доля. Згинуть наші вороженьки, як роса на сонці, запануємо ми, браття, у своїй сторонці. Душу й тіло ми положим за нашу свободу і покажем, що ми браття козацького роду. Душу й тіло ми положим за нашу свободу і покажем, що ми браття козацького роду.
Буковинський державний медичний університет – це авторитет, імідж та престиж. Це традиції, помножені на мудрість та професійність. Це бренд, створений не одним поколінням випускників. І ми з приємністю до слів привітання запрошуємо ректора Буковинського державного медичного університету, професора Ігоря Васильовича Геруша. We are pleased to welcome Rector of Bukovinian State Medical University, професор Ігор Геруш.
Високоповажні гості, дорогі викладачі, ну і шановні наші учасники 12-го міжнародного конгресу студентів і молодих вчених BIMCO-2025. Я радий вас вітати в цьому ошатному палаці академічного Буковинського державного медичного університету, з такої гарної, чудової нагоди. Перш за все, я хочу подякувати нашим Збройним силам за те, що ми можемо з вами зібратися сюди, в цьому ошатному залі, обмінятися думками, поспілкуватися і, головне, думати про майбутнє. Думати про те, як ми будемо рухатись вперед. Думати про те, як ми будемо розвивати нашу медичну науку. Думати про те, як ми будемо краще діагностувати захворювання і лікувати людей. Буковинський державний медичний університет проводить BIMCO вже 12-те. Це найбільший медичний конгрес сьогодні в Україні. Сьогодні до ваших послуг буде 9 чудових лекцій, величезна кількість майстер-класів. І при цьому ми залучили кращі клініки як міста Чернівці, так і комунальні, і так кращі клініки приватної форми власності. Сьогодні ви на своїх засіданнях можете поділитися першими вашими здобутками науковими. Це перші кроки ваші у науку. Ви те нове покоління наших молодих лікарів, науковців, які будете пропонувати нові методи діагностики, впроваджувати нові методи лікування. Ви будете покращувати охорону здоров'я населення України і не тільки України. Бо на сьогоднішній день випускники нашого університету працюють і на 5 континентах нашої держави. Я дуже радий, що ви є активне молоде покоління, яке безпосередньо бере участь у наукових дослідженнях. Хочете представити свої наукові доробки. Я хочу вам побажати успіхів, гарного творчого спілкування, гарного проведення часу в нашому прекрасному місті і в нашому чудовому закладі вищої освіти. Незабутніх вражень і успіхів вам. Dear our guest, it's our great pleasure to welcome you to Bukovinian State Medical University. This year, our forum, our BIMCO-2025, brings together around 1,000 young researchers and students from across more than 18 countries, fostering collaboration, innovation, and academic excellence. We are honored to host this Congress in hybrid format, allowing participants join both online and offline. Our deep gratitude goes to everyone who ensure our safety and enables us to gather here today. We sincerely thank our defenders for making this event possible. Over the next 3 days, you will have opportunity to engage in section meeting, 9 inspiring lectures, and 50 hands-on workshops where leading international experts will share their expertise in various fields of medicine. This year, our workshop covers an ever broader spectrum of cutting-edge topics. We include also topics in tactical medicine, mass disaster management, and latest advances in diagnostic and treatment methods. The practical session will take place in the universal clinical facilities and top municipal and private centers in Chernivtsi. We wish you an affordable experience at BIMCO-2025. May this Congress inspire you, fuel your passion for science, and empower you to realize your full potential under the peaceful skies of independent of Ukraine. Good luck for you.
Дякуємо Ігорю Васильовичу. Thank you to Professor Ігор Геруш. Організація будь-якої події вимагає виваженості та мудрості. А коли організовуєш таку масштабну подію, потрібні помічники та однодумці. Студентське наукове товариство на чолі з Анастасією Василівною КОТЕЛЬБАН вправно ведуть корабель науки до гавані перспективних досліджень. І ми радо запрошуємо до слів керівника студентського наукового товариства, доцента кафедри стоматології дитячого віку, кандидата медичних наук Анастасію Василівну КОТЕЛЬБАН. We kindly invite the supervisor of Student Scientific Society of Bukovinian State Medical University, Анастасія КОТЕЛЬБАН.
Вельмишановні учасники 12-го міжнародного медико-фармацевтичного конгресу студентів та молодих вчених BIMCO-2025. Щороку початок квітня перетворює Чернівці на осередок міжнародної наукової співпраці, об'єднуючи учасників з різних країн світу у стінах Буковинського державного медичного університету. Цьогорічний конгрес проходить у змішаному форматі, щоб кожен мав змогу долучитись до цієї масштабної події незалежно від місця перебування. BIMCO – це не лише платформа для обміну знаннями, а й можливість знайти однодумців, розширити власні наукові горизонти та отримати натхнення для нових досягнень. Ми щиро вдячні нашим захисникам, завдяки яким ми можемо проводити сьогодні цей конгрес. Сьогодні о 10:30 відбудеться пленарна сесія з 3 надзвичайно цікавими та актуальними лекціями від провідних фахівців з Туреччини, Великобританії, Німеччини. О 14:30 старт 2 циклів клінічних воркшопів, що нададуть нашим учасникам практичний досвід у різних сферах медицини. Увечері захоплива подорож, екскурсія вечірніми Чернівцями, що подарує нові враження та знайомства. Завтра о 9:00 початок секційних засідань, де наші молоді науковці представлять результати своїх досліджень, своїх напрацювань. Після засідань ще 2 цикли воркшопів, що доповнять програму практичними навичками. У п'ятницю о 9:00 останній цикл воркшопів, а вже о 12:00 панельна дискусія на надзвичайно важливу тему «Медична освіта, реалії, виклики та майбутнє». Фінальним акордом стане урочиста церемонія закриття та нагородження учасників. Дорогі учасники, бажаємо вам продуктивної роботи, цікавих дискусій та незабутніх вражень від участі у BIMCO. Нехай цей конгрес стане для вас джерелом нових знань, ідей та можливостей. Dear participants of 12th International Medical and Pharmaceutical Congress of Student and Young Scientists, BIMCO 2025. Every day at the beginning of April turns Chernivtsi into a hub of international scientific collaboration, bringing together participants from different countries within the wall of Bukovinian State Medical University. This year the Congress is held in hybrid mode, ensuring that everyone can be part of this significant event regardless of location. BIMCO is not just a platform for knowledge exchange, it's also an opportunity to connect with like-minded individuals, expand your scientific horizons and gain inspiration for your future achievements. We sincerely appreciate our defenders that help us to do this Congress today. At 10:30 we'll be opening the plenary session. 3 exciting lectures by leading experts from Turkey, Great Britain and Germany. At 2:30 we'll start 2 cycles of clinical workshop providing participants with hand-on experience in various medical fields. In the evening, a fascination tour of Chernivtsi by night hand offering new experience and networking opportunities. Tomorrow at 9 a.m. we'll start sectional meeting where young scientists will present their research finding. Following the meeting, 2 cycles of clinical workshops enhancing the program with practical skills. On Friday at 9 a.m. the final cycle of workshop followed by panel discussion at 12 p.m. on actual topic medical education realities, challenges and the future. The Congress will conclude with formal closing ceremony and the awarding of winners. Dear BIMCO participants, we wish you a productive experience, enhancing discussion and unforgettable moments at BIMCO 2025. May this Congress be a source of new knowledges, ideas and opportunities for all of you. Миру всім нам.
Дякуємо Анастасії Васильівні за теплі слова привітання. Thank you. Студентство медичного університету, окрім науки, має чудовий спектр можливостей. Хочеш займатися наукою? Будь ласка, і сьогоднішній конгрес тому підтвердження. Відчуваєш, що спорт дозволяє вивільнити зайві емоції? Приходь на кафедру фізкультури, коли душа прагне музики і релаксу, у палац академічний. І наше студентство насправді дуже талановите. І це не просто теорія. Тож вітайте оплесками Ірина Рейтеровська, переможниця міжнародних пісенних конкурсів та фестивалів. Please welcome Ірина Рейтеровська.
Опілий дим. Кожен хоче миру, кожен хоче змін. Воля в кулак. На вустах пісок, щось пішло не так. В скронях б'ється пульс, дощ іде із куль. Обрані молоді віддають життя разом до кінця. Непереможна надія, одна мрія, одне серце биття і одна доля. Я відчуваю обійми, такі сильні, одне серце биття і одна доля, одна доля, одна воля, де не піду. Бачу я ненависть і піду. Пліч опліч ми, коли боляче тобі, боляче і мені. В скронях б'ється пульс, дощ іде із куль. Обрані молоді віддають життя разом до кінця. Непереможна надія, одна мрія, одне серце биття і одна доля. Я відчуваю обійми, такі сильні, одне серце биття і одна доля, одна доля, одна воля. Не схиляти голів, залишатися мужнім, залишатися поряд перед вітром потужним. Міцно тримаєм стрій. Міцно тримаєм стрій. Непереможна надія, одна мрія, одне серце биття і одна доля. Я відчуваю обійми, такі сильні, одне серце биття і одна доля. Непереможна надія, одна мрія, одне серце биття і одна доля. Я відчуваю обійми, такі сильні, одне серце биття і одна доля, одна доля, одна воля, одна доля, одна воля. Одне серце биття і одна доля.
Ще бурхливі оплески Ірина Рейтеровська. Що ж, колеги, набравшись позитивних емоцій, ми запрошуємо вас досліджувати, слухати, аналізувати і робити висновки із нашими лекторами. І хай ці дні, проведені разом, справдять ваші найбільш очікувані сподівання – мирних нам днів, але обов'язково переможних битв на полі науки. Dear participants, we are excited to begin our plenary session that brings together one of the best specialists in their fields. Ми з радістю запрошуємо до слова нашого першого доповідача, доктора Ülkümen Родоплу з університету Дізантепе з Туреччини, який сьогодні представить лекцію на надзвичайно важливу та актуальну тему «The Power of Saving Lives». Ця лекція організована у співпраці з мережею аптек «Подорожник», що сприяє її проведенню та підвищенню рівня обізнаності у сфері охорони здоров'я. We are pleased to welcome our first lecturer, Dr. Ülkümen Rodoplu, MD, faculty at Antepe University School of Disaster Management, Turkey, with the lecture The Power of Saving Lives. Dr. Ülkümen, the floor is yours.
There is no way I can speak with these claps. I need more. It's not enough. It's not enough. More. So, I am so pleased and happy to be here. I have a 20-year-old daughter and a 31-year-old son. Yesterday, they said, "Is this an April 1 Fool's Day? Are you really going to Ukraine again?" And my wife thinks that I have a girlfriend somewhere around here. They can't understand. There is no way. They say, "Is this April Fool's Day? Are you again going to Ukraine?" Because I was here last December through WHO, United Nations, as a lecturer. And for 14 days, I had the best time in my life. To be honest, I was surprised with the alarm, the shelter, and at the end of the second day, I got used to it. And thanks to my dear doctor friend, Olena Korotun, is she around here? Okay. She was one of the doctors at that lecture, and she's the one who I had a great time with, and thanks to her for allowing me to meet you all. I was speaking with Ігоря ГЕРУША, your rector. He had a great speech, and there is no place in the world that's safe, really. I had a hard time in New York Metro. It was 11 p.m. and some guy wanted extra money from me, and he stole all my money in my pocket. And thank God that he didn't get my credit cards. And I had another problem in Amsterdam. Actually, it's the safest place, known as the safest place. Two guys stopped me when I was going to the conference hall, and they said that they wanted to check my wallet. They said that they're police, and they wanted to check my wallet. I said, "I can give you my ID. There's no way I can give you my wallet." So, going back to Turkey, earthquakes, floods, and who knows that there will be floods and disasters in Spain, but we had them last couple of months in Valencia and other parts of Spain. So, I think now we are in a family with the future doctors, my future colleagues, and I am proud of you that you decided to become doctors and pharmacists and health workers, and you are so brave. Let me congratulate you all. So, thanks to Igor GERUŠA, thanks to Oksana GODOVANECЬ. Yeah. Thanks to Anastasiya KOTELْBAN and also Anastasia Bodnar. We had a great walk this morning with her. And also my friend Olena Korotun. And also Oleksiy Boreyko. I know that he is the president. And thanks to you all. Okay. So if you let me, I can speak until the end of this Congress. So, can somebody tell me to stop, please? Who does it? Can somebody tell me that I have 5 more minutes left? Who is going to do it? Can you do it? Can you do it, please? Yeah. You say 5, okay? And can someone take a couple of photos and videos so that I can send them to my boss? Because they yes, please. Because they didn't trust me. They say, why Ukraine? Why are you going to Ukraine? There is war over there. You know, people in my country think that there is battle zone. This is battle zone. Everybody is crying. Everybody is living in tents and things like that. So I need to prove them that this is a safe area. This is the most beautiful Congress hall I have ever seen in my life. Look at this. This is great. So I need photos and a couple of videos to prove that I am here with happy people and beautiful people. Okay. The topic is power of saving lives. This is my plan. I'm going to mention a little bit about the mass casualty management training of trainers, your doctors, friends, colleagues that I have met last December. And then I will give you a couple of statistics and look at the numbers, because we are talking about the future here, and let's concentrate on what are the topics that are going to be very hot in the coming future. When you finish your medical school, the statistics will be different. For sure, the world itself is not going to be safer, but the politicians, the countries, the people will need us more. So we need to be aware of the fact that what are we going to concentrate on? I will speak about disasters. Also, I will give you a perspective from a disaster zone, the earthquake in Turkey back in 2023. I was on the hot area at that time. And I will mention about lessons learned, and then I will say a few words at the final about the future. So, this is me. I'm an emergency physician. I did my master on disaster medicine field. I'm also a family medicine specialist. Right now, I'm one of the faculty members of the university for disaster management. And my students say hello to you all. We had a lecture last week. Our lecture was on Friday, and they all say hi to you. They are all at your age, and it will be fantastic maybe to get you all together with them in a joint congress, maybe in the future. I'm the chair of an association in Turkey, I'm the chair of European Society for Emergency Medicine Disaster Medicine section for Resilient Society Working Group. And I'm also a WHO mass casualty management trainer. And I will be here for 3 days in the Congress area. I'll be around. So if any one of you are interested for more details, I'll be very happy to chat with you all. Okay, let's go back to 1 and 14th of December 2024, Kiev. In Kiev, it was a cold time. It was the coldest time. I was one of the WHO mass casualty management trainers, and we had 29 doctors from all over Ukraine. I call them the heroes, and at the closing ceremony, I cried, they also cried, and I'm very ready to cry every time. I can cry easily. And I've seen a fantastic teamwork there. We had scenarios, and we did tabletop drills. In a couple of days, I will be organizing a mass casualty management tabletop drill with 30 people. And we also had a real-life drill with the team. There were 40 students, your friends, medical students, that we did moulage and they were wounded. And there would be lots of patients coming in. Let's see this video. Here you can see doctors around the table, and we are working on a scenario. Dr. Olena Korotun is there. She's the triage officer. Patients are coming in, and Olena is doing the triage, and this is the best, the most important certificate that I have had in my life. You're going to have millions of certificates in your future life when you become professionals. You'll have many certificates. I have many, but this is the best, that's most important for me, and I was very honored to be certified. And I will never forget your beautiful country, and I will never forget your struggle. I will never forget your courage, and I will never forget the doctors' power. There are doctors in Kiev with 2 kids and still seeing patients, taking care of their 2 kids, and a housewife, and then a doctor, a pediatric doctor, and taking care of the patients under so stressful zone. So I will never forget your beautiful country and the power of the doctors in your country. And this was on media in my country. I want to share what I see with the rest of the people, with the rest of the country, so that ordinary people can know what's going on in the rest of the world. So let's move on to our topic. When we look at the world's leading causes of death, back in 2000, between 2000 and 2019, we see that ischemic heart disease comes the first, with stroke, chronic obstructive pulmonary diseases, lower respiratory infections, and then goes on. And when we look at in 2021, the causes of death, again, cardiovascular diseases and stroke is the top reasons. Let's move on to 2020, 2021. The first 3 in the United States, again, heart diseases, cancer, COVID-19, and then goes down to injury, stroke, respiratory diseases, and Alzheimer's diseases. And when we look at infant deaths at that time, 2020, 2021, we see that congenital malformations and low birth weight, sudden infant death syndromes are the third priorities. Who wants pediatrics? Who wants to become pediatric surgeon? Oh, only 2, 3? Okay. When I was at medical school, my first priority was pediatrics. I loved it. Then each year I changed my mind. So when you come up to the final, you all of a sudden find yourself in a different place. So let's go to another country, England, 2024. Let's evaluate the attribution of deaths to risk factors and broken down by broad causes of deaths. Are behavioral risk factors, dietary risks is the number one for cardiovascular diseases and cancer. So this is a very, very hot topic nowadays in the world. So, thank you. So this is a very important topic, dietary risks, and then tobacco smoking, again, is another priority. And low physical activity is the number one reason for these mostly seen diseases. So these three are the major fields to concentrate on. During your medical training, please do not forget that in the very coming near future, in 10 years, these three topics, dietary risks, tobacco smoking, low physical activity, will be the major topics people will speak about. In the United States, every day, there are 3 books published and pressed about dietary risks. And doctors do not write it. Everybody else does write it. So please, I ask my students to concentrate on diet and low physical activity. These are the areas that we all can be leaders on. Again, let's move on to another one. Let's look at the risks between the ages of 15 and 49, young ages, middle age and young ages. Alcohol, diet, tobacco, low physical activity. So these are the reasons for cardiovascular diseases, transport injuries, unintentional injuries, etc. So I share these 2 statistics for the future, to keep in your mind, please. This is very, very complicated. Let's move on to Malaysia, another country, 2023. 10 principal causes of death are again the major problems are again similar. Ischemic heart diseases. Second is pneumonia. In 2023, we have seen the risks of COVID, so that can be the reason. Cardiovascular diseases, the third row, COVID, fourth, and then goes down to transport injuries, malignancy, and etc. So countries change, the cultures may change, but we see that the priorities are similar to one another. So international relations and international knowledge sharing is very important for our profession. Yeah, again, we need to remember that COVID-19 was America's third leading cause of death back in 2020. So this is another field that we really need to concentrate, because pandemia and infectious diseases are the other priorities that we must concentrate on. So infectious diseases, public health, disaster medicine are the future professions for us. These are the fields to concentrate on, because COVID-19 was one of the most important priority for the health issue back in 2020. And according to the WHO and the other scientific associations, we know that between 2030 and 2050, global warming is expected. And this will cause around 250,000 deaths each year because of heat stress, malnutrition, diarrhea, and malaria. So these are the very, very hot topics that are waiting for us. And between 2010 and 2019, when we look at natural disasters, earthquakes, extreme temperatures, floods, storms, the roads keep on going. So the numbers will increase. The number of disasters will increase, but we know that preparedness drives down the death tolls. So, for resilient societies, we need to be leaders. We need to teach first aid, how to stay alive, how to save lives. If we don't do it, somebody else will do it. And they do it. Search and rescue teams love to give first aid courses to the public to make money. So we know that preparedness drives down the death tolls. We need to concentrate on these topics for the future of our professions and our public. We know that earthquakes, floods, fires will keep on going. For a resilient society, we need to lead. We need to have skills to contact with people, to contact with the government, to contact with the ministry, to contact with the head of our schools. We need to have the skills to contact the people. We need to be volunteers, other than working in hospitals. We need to be volunteers for the public. We need to share the skills. We know how to save lives. We need to share it with the rest of the nation. As Rowling said, we are all human, aren't we? Every human life is worth the same and worth saving. So our countries, our people, the world itself, they need us. They need us. And we need to be aware of the fact that they need us. We don't know it. We don't know how much we are worth it. We don't know how much we are valuable. We don't. We say lives, but nobody else cares. We need to be aware of the fact that we are important. I am important. If we keep this in mind, this makes us very powerful. Because our power comes from getting close to the patient. Nobody else can do it. Except my barber. He gets very close to me. I don't like it. This is very important. We get close to our patients. We have the chance for a close contact. Isn't this amazing? We can even have a closer contact to the patient. And this gives us responsibility. Remember the COVID warriors? Yesterday, the 4th of April in Turkey, in our country. Yeah, it's April Fool's Day, but it's also the Memorial Day for the health workers that died during the COVID pandemic time. It was more than 500 of them. And we need to share knowledge everywhere. Please become an international person. Share what's going on in your country. We fight. We want independence. We get killed, but we live. Please share how you live. Please share how you do it, how you succeeded. Please share what your people is doing in the shelters. Why do they keep on going down for the shelters? Please share it. Tell it. We had Marmara earthquake back in 1999. I went to 35 different countries to speak about Marmara earthquake. And now I'm visiting several countries to share how we did it back in 2023. Do it. Write it. Write everything. Everything. You may think that it's simple, but it's worth it. Sharing knowledge makes you powerful. Another very important issue for you guys. And you're going to have international friends. It makes you healthy. And it makes you safe. And you become leaders. You need to become leaders. And when you meet leaders, you realize that you can do more for the world. You can do more for a peaceful world. His name is Mesut. I promised him. This is back in 6th of February 2023. This is a man, a father holding his daughter's hand. See how close he is to her? He held her hand for 9 hours. At the beginning it was warm, but he couldn't save her. He couldn't pull her out. No machine, nobody to help. And I couldn't help him. I saw him, I spoke with him, I couldn't help him. And his 13-year-old daughter died. After 9 hours, her hand was cold. Some volunteer gave his coat to him. You see the fancy coat with orange color. And I promised Mesut, I said, Mesut, I couldn't help you. I'm sorry. I feel bad. I couldn't help you. But I promise that I will let everybody know about this. And you will not be forgotten. At the beginning of this Congress, we stand still for the victims of the war. Thank you very much for having me share this. It's very touchy for me. But we need to be aware of the issue that we cannot let the rest of the world forget about this. So keep on memorizing them and keep on looking at their picture. And I will not let my country and the rest of the world forget how devastated he was for 6 hours. Yeah, this is the 6th of February earthquake. It was 7.8 magnitude for 60 minutes. And it was 4 in the morning, the worst time for an earthquake. And this is 5 hours after one of the cities. Actually, 11 provinces were fully affected. I went to the area because it was winter time and the infrastructure was down. I went to the area with a boat. They were carrying 298 vehicles. I was the only doctor there. There were nurses, paramedics, and there were 300 people on the board. Actually, this is a boat to carry artilleries and big machines, road construction machines, etc. It's not good for people to stay in, but every vehicle had a driver, so it was interesting. And I worked with volunteers and professionals from the Ministry of Health. And on the field, as emergency physicians, we worked with volunteers, and each province was matched from the first hour by the emergency physicians. And actually, every physician was ready within 6 hours with our bags, with our tents, with our food, and with our water. And the personal equipment was ready as it was talked and practiced earlier. If you don't practice, you fail. You need to practice. You need to practice, concentrate, and keep on practicing. Otherwise, you fail. You act as a victim if you don't practice. And there are heroes. This is a nurse. Let's see this video. This is the best video. Right after the earthquake, this is a pediatric ward. She goes down to the patient's hall. All the men left the hospital. The women stay. The men always leave. The women stay. Look at her, trying to save the patients. You see the electricity is down and you see the dust all over. And she's leading. She's taking responsibility. And that's the exit. So, these are the lessons that we have learned from the earthquake. The system may not work. The system failed, actually, in Turkey because it was 11 provinces, a big area, 500 kilometer long, and 15 million people were affected. And the sistering towns were also under disaster. So We learned that the system may fail, the volunteers, the people heal their wounds, so we can be leaders to teach them how to survive and how to save lives. And we've seen that to become a resilient society, we have to learn and we have to teach one another. And we have seen that disasters will unite people. Disasters do not have nationalities. Disasters do not have borders. Disasters do not have flags. We are in a conflict with many countries surrounding us, with Syria, with Georgia, with Greece, with Armenia. But the first help came from these countries. And we have seen that during the mass disasters within the first days, we are going to have low resources, but high expectations. And the goal there, the goal for disaster management is again back to our keywords, saving more lives. But before doing this, before saving more lives, we need to have security. No security zone, no saving lives. You cannot save lives. You need security at the beginning. Because if you have security, you can start doing triage. Shelter, food, water comes with it. And with triage, you can start doing first aid. So for first aid, you need volunteers. You need public. You need ordinary people on the area. And we know that during the disasters, the best leader is the one who saves the most lives. So let's look at the future for disaster medicine, disaster management, for our profession. We need to think of the animals. Animals, I mean pets, sheep, donkeys, horses for the people. Because if you do not put the animals in your disaster plans, that means you lose the animals, but it's also the end of the man. You lose the people. Because of economical reasons, and again, after earthquakes, we realize that people go inside again to save the lives of the animals. So you need to put them in their plans. Please keep this in mind. Think of the autistic patients. There are many of them. Think of the Alzheimer's patients. In the coming future, dementia, Alzheimer's, and neurological emergencies will be the top 3 priorities in the world because we are getting older. So please do not forget them within your plans. Don't forget the kids. Don't forget the kids how to survive, how to save lives. Put them in your plan. Our kids need to know that we are humans, we have brains, and if we trust and believe in science, we can deal with nature. Please do not let them see you crying. Please do not let them see you devastated. And think of the handicapped. The future must have handicapped people included in the disaster plans. I come from Izmir. Back in 170 after Christ AC, there was a man, Damokaris. This is a statue that was made for Damokaris. And on this statue, it's written, says, "O Judge Damokaris, famous with his skills, this success also belongs to you." after the awful mortal disasters of an earthquake, with a very delicate work, you also succeeded in making a city out of Smyrna again. Smyrna is Izmir. Back in 170, Damokharis did so many that now everybody else in this room knows who Damokharis is, because he saved lives. So, thank you very much. It was a great pleasure. This is the end of my lecture. It's a big honor to be here again, and I'll be around. You didn't? Is it? Oh, okay. So I have 6 more minutes left. I love this. Any questions, please? Yeah. But first of all, yes, you can clap.
So much, Dr. Ilkeman, and so we'll proceed with the questions. Yeah.
So thank you so much for your great supportive speech and really interesting presentation. My name is Matvey Darychuk. I'm from Bukovинського Medical University, Department of Psychology and Philosophy. So you have mentioned different points of death statistics and disasters health management. Also, you have mentioned behavioral factors such as drugs, alcohol, etc. But probably it's more symptomatic than the reason. So when we are talking about physical health and healthcare system, we should observe it from the biological, psychological and social factors. So my question is, what do you think about including psychological point of view or mental health specialist in your future researches? And generally, in your opinion, do you think that it is important because statistics of anxiety, depression, PTSD and suicide is increasing? Thank you so much for your presentation.
Yeah, thank you, thank you, thank you. I love questions that have answers, you know. So my answer is I agree. But to put another thing with this, I need to say this, that I read an article yesterday in the airplane. I had magazines I was reading. This is fantastic. You will like this. It was published on JAMA, and post-traumatic stress syndrome. After war, during war, after earthquake, during earthquake, floods, wildfires, etc., etc. Terrorist acts. Post-traumatic stress syndrome equals depression, anxiety, and this, when you go further to 10, 15 years, the percentage of you becoming cancer or having cardiovascular disease increases 10 to 20 times. So, wartime, I have depression because of post-traumatic stress syndrome. I see many patients and I got messed up. And 15 years from now, I will become 10% higher probability to become cancer or cardiovascular disease. So this is a very, very important topic. Thanks for asking. We need to keep this in mind, please. Thank you.
Thank you so much. Next question.
Okay, so first of all, I'm really grateful for your presentation, and I'm a student of Bukovin State Medical myself. So, okay, I would like to talk about one crucial aspect. So first of all, I have a very deep interest in oncology, and when it comes to giving the first medical aid, we need to understand that in our reality, we basically give this first medical aid not only to primarily health patients, but to cancer patients as well. So I would like to clarify if there any difference when it comes to giving the first medical aid to cancer patients and to like usual ones, and if so, which exactly difference do we have?
Okay. I have a YouTube channel. It's in Turkish. And This is the Cancer Week. Between the 1st of April and the 7th of April, it's Cancer Week. And I put on a video in Turkish and talking about this. Here, I am very happy that I graduated medical school 3-4 years ago. And I'm very honored and very, very thankful that all the cancer treatment issues have changed. Less surgery now, no radiotherapy at all, and only few medicine now. Now we know that the cancer cells are very smart, very naughty. They're like kids. You need to control them. You need to let them do whatever they can do, but you need to control them. If they're out of control, they can harm themselves. But the cancer cells do not harm themselves. They stop we call it a jammer. They stop our immune system signals. So if the immune system signals are stopped, then the immune system just stands there and cannot fight. But during the pandemic era, when people were trying to look for new ways to find a vaccination, mRNA vaccine has started a new era for cancer. And I'm positively sure that in 5, 6, 10 years' time, we all are going to be safer. We're going to have new diseases to fight with. But for cancer, we're going to succeed to fight against them. So for the public, we need to give them this signal, actually. If you have risks to have cancer, if you have DNA for cancer, if you have relatives, mother, father, uncle that do have cancer, then you need to work within a team and learn how to survive, how to do diet, how to do physical exercise, and how to take care of yourself and learn the signals of the body. So this is a very, very essential field for medicine, actually. And in the very near future, I'm positively sure that we're going to have much, much better results. And for the public, it will be a good thing to learn, because the word cancer scares everybody, and they don't want to have this disease announced. But it's one of 3,000 diseases, actually. Thank you for the question.
Thank you so much. Does anyone has any questions?
Hello, sir. Myself, Sahib. I am from Bukovinsko University, and I am in 6th course. Sir, I want to ask that in your presentation, you talked about Myanmar, Spain, Syria. So I want to ask that right now, one of the biggest genocide which is happening in Gaza. So what is your contribution right now for that country, that city?
In my presentation, I mentioned that we need to be leaders because we know how to save lives. We know how to survive. So for a person, for a doctor, there is one priority. We are against wars. We are all against powerful countries trying to kill people, killing people, and have them suffer. And in Gaza, many health care providers were killed. And this is insane. So if we win, if as doctors, if as health workers, if we win, that the world must be safer, and insanity, insane leaders who cause to kill people and who are reasons to kill people, we need to give an end to their eras. And I positively and definitely do support peace and independence for every country. Thank you for asking and bringing this topic here.
Thank you so much.
My question is, your presentation is on the disaster management, correct? And you're also associated with WHO. So what your critical thinking is saying when it's about lots of patients, whom do you prioritize first? Like the one who has brain injury, the one who has heart injury, or the massive bleeding? So when there are a lot of patients around you, whom do you think that I should treat first? Like, what is your critical thinking and what should we think about it?
Many patients, and who do you think you should save the first? Who is your priority? The ones who I can save. To give an example, I don't look at their age. I don't look at their nationality, their color. I don't even look at if they're my relatives or not. I look for the ones who I can save. So as WHO, we have a plan, mass casualty management plan. We start with walking and non-walking. So when you have 100 patients, we know that 70% will be walking. We call them green zone patients. They can stay. They can move on to another area. Our emergency department must be kept for the red zone patients, the ones that I can save if I see them. Thorax trauma, mass bleeding. But I need to let go some patients, like 70% of their body is burned, 2 legs amputated under a crash or bomb or whatever. In an ordinary day, I do my best to save his life with all my team, but in disaster, I put them in a blue zone, which means expectant. If I finish everything, at the end of the day, I go see him again. But in these each groups, green, blue, I need health professionals, a nurse, a doctor, to evaluate them. I mean, I just don't let them stay there. This we call triage. So, the answer to your question is, in one sentence, the ones who I can save. Thank you.
Thank you, and thank you so much, Dr. Ilkuman. And we are really grateful for your incredible presentation and answering all the questions, and all participants who will have more questions to our doctor, please ask them during our next days of the Congress. Thank you so much, Dr. Lukman. Thank you. Наступним ми маємо честь представити нашого давнього друга та висококваліфікованого експерта, доктор Зул Мірза, the past president consultant in emergency medicine з Лондона, Великобританії, який поділиться з нами своїми напрацюваннями у сфері медицини невідкладних станів у межах лекції на тему Major Trauma Update. Ця доповідь, безумовно, стане надзвичайно корисною для всіх, хто працює у сфері екстреної медицини та прагне вдосконалювати свої знання та навички. Dear participants, the next hour lecture is our old friend, Dr. Zul Mirza from London, UK, who will share his experience on the topic Major Trauma Update. Dr. Zul, we are so happy to see you on the screen, and we'll be really happy to see you hopefully next year here in person in Chernivtsi. Yeah, and we also kindly ask all our participants to remember about the basics of copyrights and intellectual property, and we kindly ask you not to take any photos and videos of Dr. Zul's presentation unless he will give his own consent on this. Дорогі учасники, ми будемо просити вас зберігати свої знання із прав інтелектуальної власності і не робити фотографій та відео із презентації доктора Зула, тільки якщо він дасть на це згоду. Тобто, якщо він не дає згоди, ми, будь ласка, фото і відео презентації не робимо і не використовуємо її у власних цілях. Дякую. So, Dr. Zul, the floor is yours.
Great, thank you very much indeed. Can you hear me okay?
Perfectly.
Great, thanks very much. BIMCO, and thank you very much for inviting me to give you this lecture. I think I've been coming to BIMCO since, I think, 2018 or something, and I'm sorry I cannot be there in person, but for political reasons, I'm not able to come, but I hope that to be there in person next year to give a lecture if you invite me, and to run some more workshops. So thank you very much. So I'm going to give you a quick update on trauma, on major trauma, give you some cases, some real cases as well. And then I have some questions for you, which you should think about. And then I'll give you the answers at the end of my talk. And if there is anything else specific, I will leave you with my email address as well, so you can contact me should you want to. So here we go. Thank you very much. So this is where I work. Can you see the new slide? Is it ticking over?
No, just the first one.
Okay. Now?
Unfortunately not.
Okay, so I don't know what's going on. So what would you like me to do?
Probably you need to stop sharing and try to share it one more time.
Okay, let's have a look. Let's. Can you see that now?
Yes, we can see your screen, but
Okay.
without any slides.
Can you see my slides?
Unfortunately not. And here is like a mirror effect.
Now? Can you see that?
Not yet.
Okay, what would you like me to do?
Okay, so you need to stop sharing one more time. Then you need to share your screen and choose your presentation and just sharing the screen. And press F5 or start sharing. Yeah, perfect. And can you try to click? Yeah, perfect. It works perfectly.
Great.
Thank you.
Perfect. Thanks very much. Thank you for that. So this is my hospital in London, just to show you where I work. This is a very unusual slide for us. This is my emergency department where there's only one ambulance. But actually, this is much more like it because we can see nearly 200,000 patients in the emergency department. So it's a very busy, one of the busiest emergency departments in the United Kingdom. So trauma case number 1. This was an 87-year-old female who had a fall. She had a pulse of 107. That's her saturations. I'm just going to summarize the history and examination findings because the lecture is very short. So I don't have time to go into everything. That's her blood pressure and that's her respiratory rate. And she was given some morphine by the London Ambulance Service. This is her ample history, no allergies. She's on these medications. She's got all those medical conditions. And she last had something to eat 6 hours ago. And this is an elderly lady who lost her balance and then fell and hit the right side of her chest on the chair. On examination, she was talking. She had no cervical spine tenderness. She had some chest wall deformity. In C, no obvious hemorrhage. She was a bit drowsy, but rousable, and no other injuries identified. So we did a scan of her head, C-spine, and chest, and this is what it showed. So basically, she had some rib fractures, which you can probably see here, and a hemothorax. I just want to talk a little bit about rib fractures because, especially in the elderly, it occurs in about 10 to 15% of all trauma admissions. And 2/3 of them have a very complicated scenarios. And the mortality can be very, very high with these patients. And I'm going to talk about this a little bit later on. I don't know if the audience can shout out an answer, but can someone shout out to the invigilator, to the chairwoman, of what these patients might die of? And then maybe you can give me the answer. If anybody answers that question, what do people with rib fractures die of? Maybe everyone's very nervous to answer the question, but so I'll carry on. So 30% of these patients may develop pneumonia, and that's what we're worried about in these patients. The second case, and I'll summarize all of this a bit later on. I just want to go through the clinical cases first. The second case was a male, but we didn't know any name or anything, came in intoxicated, so was very drunk, brought in by the London Ambulance Service. And he fell off an e-scooter. So we didn't get much of a history from him. And he'd lost consciousness. He had noisy breathing. And he was very combative. He was fighting everybody, very confused when he came to A&E. So in the emergency department, we tried to immobilize him, but he was fighting everybody. So we had to give him a benzodiazepine to calm him down. He had a low saturation. His capillary refill was normal. His blood pressure was 150/79. His heart rate was 117. Abdomen was soft. He was bleeding from the right ear. And those were his GCS scores, E4, V4, M6, eye, verbal, motor. And he was bleeding from the right ear, and he had a laceration over his occiput at the back of his head. And because he was fighting a lot, we couldn't get him into the CT scanner. So we had to intubate him and anesthetize him. And we did a trauma series for him. And this is what it showed. So I'll give you maybe 10 or 15 seconds to look at this scan. And if somebody wants to shout out the answer, then maybe you can tell me the answer. Any answers? So this person, you can see on the head, he's got a hematoma there. He's got this swelling around here. And because this is lens-shaped, like a lens, this is an extradural hematoma. And in addition to this, he's got some rib fractures as well. So both a head injury and rib fractures. And I keep mentioning rib fractures, and I want to talk about it a little bit later on. The next case is a 46-year-old male who came to the hospital after he'd been assaulted. We weren't sure how long he lost consciousness for. And this is his history: no vomiting, no neurology. He had a scalp laceration, upper lip swelling. Patient lived on his own, and patient then discharged himself. Then he came back, and this time he'd had 2 seizures, 2 fits, with no history of epilepsy. He had one at home and one in the department, and then he began to vomit. So now we know that he's probably got a head injury and he's vomiting. On examination, he had raccoon eyes, which I think some of you will know is a sign of a skull fracture or basal skull fracture. His respiratory rate was 26. His heart rate was 98, blood pressure 152/87, abdomen soft, people equal, and peripheral nervous system examination normal. And that's his scan. Have a look at this scan and imagine you're a junior doctor and you have to explain this scan to your boss. What would you say? Just have a think about it, and then I'll give you the answer as well. So you can see on this scan of the CT scan of the head, there's a lot of edema here in the frontal lobes and the temporal lobes. There's bleeding and swelling. And so with all of these cases, remember that there are signs of raised intracranial pressure and there are symptoms of raised intracranial pressure. So he was vomiting, so that's a symptom. And then the signs, you're looking at the pulse, which would be slow, the blood pressure may be high, they may have abnormal breathing. And remember, you should do a full peripheral and a cranial nerve examination, especially looking at the 6th cranial nerve and the 3rd cranial nerve as well. Because remember, the 6th cranial nerve has a very long intracranial course as well. So you have to do a full cranial nerve and a peripheral nerve examination. So this patient was intubated and then dealt and referred to the neurosurgeons. And that's another aspect of his CT scan. Another case, these are all real cases. 73-year-old female, she was assaulted by her ex-partner and she had pain in the left side of the chest and abdomen. So initially the doctor requested a chest x-ray. Can anyone see is this chest x-ray normal or abnormal? Can you see anything on this x-ray? So it's important when you look at a chest x-ray, everybody does the airway and then looking at the B for bones and breathing and C for circulation, D for diaphragm, E for everything else and extra tissues. And when you look at a chest x-ray, the other thing that I like to teach is that you should look for the apex. And in the apex, I'm sorry I'm not there in person, so I can't ask you the questions and interact with the audience. It's very difficult on Zoom, but I'll try. So you should look at the apex of the chest x-ray, and you're looking for a very small apical pneumothorax. And that is important in trauma, because if you have a pneumothorax and then you intubate a patient, you can convert a kind of a normal pneumothorax into a tension pneumothorax. And when you have a tension pneumothorax, then of course that can then push your mediastinum and the rest of your chest onto the opposite side. And as that happens, you get reduced venous return, and eventually you can have a cardiac arrest. And if you remember, in a cardiac arrest, there are 4 H's and 4 T's. And remember, the H's are hypoxia, hypovolemia, hypokalemia, hypothermia. They're your 4 H's. And then your T's, your tension pneumothorax, your toxins, your tamponade, and thromboembolic phenomena. So the T is for the tension pneumothorax, and this is what may lead to a cardiac arrest. So this is why it's really important to look for a pneumothorax, especially a small one in the apices of the lungs. The other area to look at is to look at the costophrenic angle, which is the basis and the corner of the lungs, to see if there's a hemothorax, even a small one. And then what you should look at is look at the heart, and you've got to look at behind the heart and around the heart. And in the case of trauma, you're looking around the heart to see if there's any air, pneumomediastinum, or pneumopericardium around the heart. And then behind the heart, sometimes in trauma, you can get a diaphragmatic hernia, which can herniate through and appear behind the heart. And the final area to look at is in the superior mediastinum, because in the case of trauma, you can get thoracic rupture. And some of you might remember Princess Diana when she had a car crash in Paris in the tunnel. She ruptured some of her great vessels, and she would have had a widened mediastinum. So a chest X-ray can give you a lot of information. But, and it's a very important but, you can't trust the chest X-ray all the time, because sometimes the chest X-rays lie, or you can't see what you're meant to see. And in this situation, there were some rib fractures which could have been easily missed. So if you look very carefully on the left-hand side, you can see some rib fractures. And on a chest X-ray, we now know that you can miss up to 50%, 50, up to 50% of rib fractures. And that's a lot, right? If you were going to cross a road and you had a 1 in 2 chance of being hit by a car, you would think very carefully before you cross the road. And therefore, if the history, i.e. the mechanics of the fall or the mechanics of trauma, are inconsistent with the investigation, whether it's a chest X-ray, whether it's the sodium or the potassium or the CK or anything, if the history is not consistent with your examination findings, think again. Don't try and just match it up unnecessarily and force your mind into one diagnosis. If your clinical suspicion is suggesting something, go with your clinical suspicion. So in this case, we had a clinical suspicion that the patient had some significant rib injuries. So if we go to the next CT, we can see, look at all of these rib fractures. And this was not visible so well on the chest X-ray. And that is why now in the 21st century, with all the data from trauma, major trauma throughout the world, we have lowered our threshold for doing CT scans because it's way more accurate than a chest X-ray or X-rays in this context. And remember, the reason I'm spending some time on this is to emphasize the importance of rib fractures. Historically, we used to say rib fractures, don't worry about it, they'll heal themselves, it's okay. But now that we've started to scan more and more people, we're realizing how extensive the injuries can be. And the key question here is, what is the high morbidity and mortality associated with multiple rib fractures? And the answer is developing underlying pulmonary contusion and then a pneumonia. And of course, we now know a lot of major trauma apart from, apart from wars, and which I'm completely aware of and stuff. But even in non-war areas, it's from elderly people falling from a standing height. And therefore, these are the people who have very high mortalities. And unless we make this diagnosis and scan, then we might not pick this up. So always look out for rib fractures and underlying pulmonary contusion, which you may not be able to see on a normal chest X-ray. And you can see this flail segment. And remember, the definition of a flail segment or a flail chest is 2 or more consecutively fractured ribs in 2 or more places. In other words, you've got one part of the chest wall which moves almost independently as you're breathing in and out, in and out. And this is a closer picture. As you look, you can see all of these fractures along here, which you could not see on the chest X-ray. And this is your flail chest. As I said to you, you've got 2 or more rib fractures broken in 2 or more places. So you've got this independent movement of the chest. And this is the bit which then goes and smashes against the lungs, causing bruising. But you can't see it necessarily because it's inside the lungs unless you do a scan. Whereas if you bruise someone on the arm or somewhere else, you can see the bruise. But in the lungs, you might not be able to see it on a chest X-ray. And this is just to re-emphasize the point that elderly patients with chest wall injuries often have severe associated traumas. And that's why they have a high mortality and a high morbidity. So you don't have to have fallen off from the first floor or the second floor or have a major road traffic accident to have severe injuries. So what is new in trauma now? Because there's a lot of things that have changed. So what I'm going to do over the next 15, 20 minutes, and I'll allow you some questions at the end, is to give you the update from the new advanced trauma life support guidelines, which is from the US, about what the ATLS courses are now teaching when I lecture on ATLS courses. So the best way to learn something, the best way of identifying knowledge is to know where the gap in your knowledge is. So I'm going to ask you a few questions, and I want you to answer the question just inside your own mind, inside your own head. You don't have to shout any answers. And then we will see how many of these you've learned from. Because once you've identified the gap in the knowledge, and then the answer comes, then you're much more likely to remember things 10, 15, 20 years along the line. So my first question, it's all kind of new now in trauma, relatively new, is what is the definition of major trauma? Have a think about that. What is the definition of major trauma? Who has the highest mortality from trauma, both in the UK and the Western world? Who has the highest mortality? In fact, this kind of applies to the whole world, not just United Kingdom. So that's the who. What is the mechanism of injury which causes this very high mortality? What is the mechanism of injury which causes this high mortality? I've kind of given you some answers already, but I just want you to see if you can make the connection in knowledge. What proportion of rib fractures, I've given you this answer already, what proportion of rib fractures can be missed on a normal chest X-ray? What is the main prognostic factor in chest injuries? I've given you this answer slightly already. What is the main prognostic factor in chest injuries? So I hope you've answered these questions, and then I will give you the answers. What proportion or percentage of cervical spine x-rays will miss a fracture? What proportion of cervical spine x-rays miss a fracture? Just answer it in your own minds. This is a very powerful way of learning. What proportion of those fractures in the C-spine have a second fracture? So what proportion of a cervical spine x-ray where you see one fracture, is there a second fracture? What is the link between a normal neurological examination and clearing the cervical spine? What is the link between a normal neurological examination and clearing the cervical spine? How many times does warfarin increase the chances of an intracranial bleed in a head injury? Because remember, when somebody comes in with a head injury, one of the key questions is, are they on an anticoagulant? And that includes, by the way, aspirin and clopidogrel and the super aspirins. You must ask that question. What does REBOA stand for? R-E-B-O-A. What does REBOA in trauma stand for? So what's new? I'll answer those questions at the end. So now I've got you thinking a little bit. So what's new in trauma? It used to be primary survey, A, B, C, D, E. Airway with cervical spine. Breathing with oxygen, connected and turned on. So it's not just B for breathing. B for breathing with oxygen, connected and turned on. Because sometimes people connect, but they don't switch it on. So that's why we say breathing with oxygen, connected and turned on. C for circulation. No, incorrect. C for circulation with hemorrhage control. So they all come with something. A comes with airway with cervical spine control. B comes from breathing with oxygen connected and turned on. C, circulation with hemorrhage control. D, disability with pupils and AVPU, alert, verbally responsive, response to pain, and unresponsive. AVPU, alert, verbally responsive, pain response, unresponsive. So D comes with two things, pupils and AVPU. And AVPU is a quick way of working out your GCS. And finally, we get to E, exposure. No, incorrect. Exposure without causing hypothermia, because we know that when you undress somebody, you can make them very cold, especially in the winter. And now we know the new things in trauma is that for every degree fall in your body temperature, your clotting mechanism goes strange, it goes funny, so you bleed even more. So what do? So we undress the patient for exposure so we can see where the wounds are, but then we make the patient cold and then we interfere with the clotting. So we have to say exposure without causing hypothermia. So remember these things. So they all come with something. So that's the primary survey. The purpose of the primary survey is to identify limb-threatening injuries, and then to resuscitate and then reassess. So in trauma, you identify the life-threatening problem, you treat it, and then you see the effects of the treatment. That's where you reassess. So treat, identify, treat, reassess, and then go back to A, B, C, D, and E. And they occur in that order because you're much more likely to die of an airway problem than you are to die of a breathing problem, than a circulation problem. But of course, in reality, we try and treat everything at the same time, but just for the purposes of doing things systematically. So that's a primary survey. So what we've changed in trauma is that preparation is now coming in front of the primary survey. And by preparation, I mean you've got the correct team ready. The trauma call has gone out. The right surgeon, the right orthopedic surgeon, the right emergency doctor, the right drugs, the right fluids, the pelvic binder, the everything that you need is all ready, and getting the blood ready. If you've got O negative blood or cross match, whatever, you must have everything ready so that when the patient arrives, you are ready to go. So that's why what's new is that preparation is very, very important. Then we do the primary survey. We've done the resuscitation, and I'll talk about that in a minute. Then we do the secondary survey. Well, what's new? What's new in trauma is that the secondary survey, we have now found out it misses some significant amount of injuries. So you do the primary survey, you do the secondary survey, and now you do a tertiary survey, because after you've had the operation, after the patient's making a recovery, then you find they've got a fractured scaphoid, or they've got a peripheral nerve injury, or something else going on that was not obvious at the beginning. So that's why it's now we've added in secondary survey, tertiary survey, and sometimes you need to do a quaternary survey, a fourth survey. So there's a lot of things to be doing because a patient's situation is dynamic. It's changing. Assess, reassess. Assess, reassess. So one of the things in trauma now is that the first clot is the best clot. And the reason we say that is that historically, what we've done in trauma is that as soon as the patient comes in, we give a lot of fluid. And sometimes we overdo it with the fluids. And therefore, as you give the fluids, you can dissolve or pop the first clot. And as the second clot forms, it's not as strong as the first clot. So it becomes more what we call friable. It breaks easily. So that's why we say you don't want to get the blood pressure too high. So it's got to be within a certain limit depending on the age of the patient and other comorbidities. So we have changed how much fluid we might give at the beginning before we assess and reassess. And also remember, this links in to a drop in your body temperature as well. So bear that in mind. So what else is new? Now, historically, we would intubate people who were low in the GCS. Now, if I was in Chenifsi now, I would be asking you quite a few questions and interacting with the audience, but I can't do that. So I will answer my own questions. Historically, we used to intubate patients who were in coma or had an airway problem with a low GCS, Glasgow Coma Scale. But we've added something else in now. We've started to perhaps intubate more people who are being very aggressive and agitated, as one of the cases I presented at the beginning, because the data now shows that actually if we intubate some of these patients, we can get them into the scanner quicker and find out what's wrong with them quicker. And if they need an operation, we can do that quicker. So intubation is not just for people with a low GCS and an impending airway problem. It can also be used for very aggressive patients in whom we need to be able to make a diagnosis. And that's been shown to reduce mortality as well. So that's new in airway and primary survey. So the next question is, how do you clear the cervical spine? And is a normal neurological examination sufficient? So this was one of my questions to you. Well, historically, we've said that in order to clear the cervical spine, you can't have any kind of bony midline tenderness and normal neurology, no alcohol on board or drugs on board, no distracting injuries. So actually, you could do a neurological examination, but if they have a distracting injury, if got a fractured femur, a fractured pelvis, you might not be so confident in clearing the cervical spine, which is why we may have to lower our threshold for doing a CT scan in these patients. And there are some people who believe now that if you're doing a head CT scan, you might as well do the C-spine as well, because obviously the head's connected to the C-spine. And if you've got drugs and alcohol on board, then you can't do a proper clearance of the C-spine. So please be extra careful with that, because there may be a distracting injury, and your sensorium, your pain thresholds might be affected by drugs and especially alcohol. What's new in breathing? So historically, we used to do a chest decompression in the second intercostal space in the mid-clavicular line. Now there is more of a move to do it in the safe triangle where we put the chest drain in. And this is from some cadaveric studies, which I think were done in Sweden, which showed that the success rate in the safety triangle where you put the chest drain in is much better than doing it up here where there are less great vessels, etc. So we've changed the site for the decompression. In breathing, there's a mnemonic, which is called ATOM FC. So remember, the purpose of the primary survey is to identify life-threatening injuries. And when you're in a trauma situation, people might be panicking, running around, not thinking properly and stressed. Just remember this mnemonic. It's an easy way of remembering things in an emergency situation. A stands for airway problem. T stands for attention pneumothorax. O, open pneumothorax. M, massive hemothorax. F, flail chest. C, cardiac tamponade. So if you remember ATOM FC, you have nearly excluded a lot of the main life-threatening conditions in A and B. Airway problem, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, cardiac tamponade. But in the new advanced trauma life support guidelines, they've removed the flail segment bit and put in a tracheal bronchial injury to make you think about this as well. But it's worth bearing in mind ATOM FC. It's a quick way of triaging life-threatening problems or making you think in a very stressful situations. And I keep mentioning the fractured ribs again and how there's a high mortality with it. What's new in circulation? What's new in circulation? Well, what is the definition of shock? You know, I saw George Clooney and I was in shock. No. Definition of shock is inadequate tissue perfusion and oxygenation. So not enough oxygen getting to the tissues, which then become ischemic and the cells swell up and they burst. So there are 4 different grades of shock. And unfortunately, I don't have time to go through everything. There's grade 1, 2, 3, and 4. Grade 1 is up to 15% of blood loss, grade 2, 30%, grade 3, 40%, and grade 4, 45, 50%, roughly speaking. It's like a game of tennis. 15 love, 30 love, 40 love, game, set, and death. So just as a rough guide, that's the easy way to remember it. But now, in order to work out the different grades of shock a person is in, the trauma guidelines have added in base deficit as well. So 0 to 2, -2 to -6. So the more acidotic you're becoming, the worse the prognosis. And this has helped when you do the blood gas, it's helped to make a more accurate diagnosis of which grade of shock you're in. Because the different grades of shock will require different treatment. For example, grade 1 shock doesn't need too much treatment, maybe just a little bit of fluid. I get a grade 1 shock every morning when I shave, but I don't need much doing. I drink a bit of water and I'm okay. But as you go down the different grades of shock, you're losing more and more blood. So remember, in grade 1 shock, your pulse and blood pressure might be normal. In grade 2 shock, your pulse is definitely usually up, but not a lot of people look for what's called the pulse pressure. So your systolic might stay the same, but your diastolic comes up because the diastolic component of your blood pressure is exquisitely sensitive to the circulating catecholamines released when you've had trauma and blood loss. So a good, clever doctor doesn't say, oh, what's a systolic or what's the blood pressure? They look at both the systolic and the diastolic. So if you've got narrowing, you're in grade 2 shock usually. So that's a little clue before you go into grade 3 shock. When you start dropping your systolic blood pressure, now you're at 40-45% of blood loss, and now you're in trouble, or not you, but the patient is in trouble. So that's why the next time you see a patient, you want to look at both the systolic and the diastolic, not just the systolic. And by the time they drop the systolic, you've got to act really quickly because you're only 10, 15, 20% away from a cardiac arrest. So if you learn nothing from me today, my take-home message is that once you start dropping your systolic in the context of trauma, you've got to act quickly. And there's only one solution to that. There's only one solution in the context of trauma. I think the previous speaker who gave a very, very good talk was talking about major trauma and earthquakes, etc., etc. But a lot of these patients, if they're the number one cause in the context of major trauma is blood loss in this context. So always bear that in mind. And there's only one treatment for blood loss, and that is stop the bleeding. In other words, they may need to go to theatre. Anything on the outside, you can put a bit of pressure on, but you can't see the inside, and that's a problem. And that's why you've got to rely on these parameters, the pulse, the blood pressure, the base excess, how acidotic they are, and so forth. So what's the role of fluids? So what's new in fluids? How much? What? Why? So I can't talk about the rest of the world. I can talk about what we're doing in the United Kingdom. And we tend to use plasma light as a more kind of neutral solution because normal saline pH is about 5.5. So we tend not to use that in this context. So we use plasma light here, or Hartmann's. I think it's reasonable as well. And now one of the things that we're kind of advocating, again, depends on the patient, depends on your own policies and procedures and where you're working. But I think the received wisdom at the moment is that once we give more than 1.5 liters, there's some evidence now that shows that the mortality is going up after that. Why? I take you back to one of my slides where I said the first clot is the best clot. And therefore, if you potentially give too much fluid, again, you've got to balance it against the comorbidities and lots of other conditions. This is just a general statement, not supposed to be the rule of law as per se. Then you burst the first clot and you keep giving more and more fluid, and it's just coming out at the other end. And that's why I said that, and that's why this is associated with higher mortality, which is why I've said that once you start to drop your blood pressure, there is only one solution. Well, the main solution, the major solution is you've got to stop the bleeding. If you've got a tap, you've got to turn the tap off. There's no point just giving lots and lots. But in some instances, I understand that you might have to give some to maintain blood pressure, but you've got to try and identify the bleed and take them to theatre and stop the bleeding as soon as is reasonable as the facilities allow. Now, when somebody's a massive transfusion, the definition is if you've given them more than 4 units of blood, 4 units or more of blood in 1 hour, or 10 units in 24 hours. One of the issues that's now being noticed, and people don't necessarily think about it, is that as you give massive transfusions, more and more blood, you start consuming calcium. So bear in mind, and please check with your own local hospitals and policies, but here in the UK, we're beginning to give more and more calcium with this so that they don't become hypocalcemic, because it causes a consumption, consumption of the calcium. So just to bear that in mind. So that's what most often forgotten. This is a slide which I can't remember which somebody used this in one of the lectures I was giving in Berlin, in Germany, I think. And basically what he was saying, he was an ER doctor as well. And he was basically saying, there's a lot of education around, please stop the bleeding, because everyone's rushing around doing this and this. You've got to diagnose it and stop it. So if you learn nothing from me, it's about stopping the bleeding. That's what saves lives in the context. There are lots of things that save lives. I accept that. But in the context of hypovolemia in trauma, stopping the bleeding saves life. That's whether it's a tourniquet, whether it's and normally they would have to go to theatre to stop the bleeding. I've covered this already. Now, when a person is in shock and they're beginning to drop the systolic blood pressure, I want you to think, where is the blood? Because the problem is that if somebody has a nosebleed or somebody cuts their arm from whatever reason, you can see the blood. Therefore, you run around trying to stop the bleeding. But in the context of major trauma, the blood can be in the chest, in the abdomen, in the pelvis, in the long bones. But there are two places that people don't think about, but they must think about it. And the extra two places which are often forgotten are the retroperitoneum at the back. But you can't examine that well. That's where we end up doing the CT scans. And the final place where the blood is at the scene of the accident, at the scene of the trauma. So when the ambulance and the paramedics bring the patient into the hospital, not only do you examine the patient, but you must talk to the paramedics, the people who brought the patient to the hospital, and ask them, how much blood was there at the scene? Because they'll give you the answer because they were there. And that's really important. And these are the hidden areas: the chest, the abdomen, the pelvis, the long bones, the femur, etc., the retroperitoneum, and at the scene of the accident. That's really important to ask that question. What's new in the abdomen and pelvis? Historically, we used to do a digital rectal examination to look for a high-riding prostate. But the evidence now is that that's not very reliable, especially now that we're doing more and more scans. And pelvic fractures in the elderly, they often end up requiring more blood than somebody who's younger, and these patients stay in the hospital longer. And I remember going to a lecture, I was giving a lecture, I can't remember which country I was in when I was giving this lecture, but I also went to somebody else's lecture. And one of the things he said, which I learned from, and I still remember today, and I now teach it to you, which is, he said, I have been a geriatric doctor, a doctor for old people, for about 35 years. And he says, I can summarize my career of 35 years in one sentence. And that sentence I remember today. And that sentence was, the only thing which is typical of the elderly is that they are atypical. The only thing which is typical about the elderly is that they are atypical. What does that mean? In other words, elderly people present in a way which young people don't present like, so their symptoms are not classical. Elderly people with a heart attack will present with confusion, diarrhea, and vomiting, not necessarily chest pain. Elderly people with pneumonia might not have the shortness of breath or the cough. They may only present with confusion, diarrhea, and a high respiratory rate. And elderly people with trauma will not present in the classical way of just dropping the blood pressure, etc., etc. Because remember, as one gets older, your blood pressure gets a little bit higher. Therefore, a normal blood pressure in the elderly coming in with trauma might be hypotension. So they might be in shock. So bear that in mind. This injury, it might look very trivial. This is the buttocks of a man who got stabbed. But when you see a small injury like this, buttock injuries, there's a very high association with bowel injuries. So anyone with buttock injuries, you must have a look at the bowel. Very important. Musculoskeletal, what is new in this? What this is really saying is that people who come in with musculoskeletal injuries, bilateral femoral fractures, very high mortality. Don't forget open fractures and antibiotics. Tourniquet saves lives. Tourniquet saves lives, but you must put the time you put the tourniquet on. Remember, you can have an open fracture, but still have a compartment syndrome. Very important. Open fractures, you can still have a compartment syndrome when the pain is out of proportion to the clinical findings. When someone is in a lot of pain, think, could this be compartment? And pelvic fractures we've covered already. Silver trauma, geriatrics. In this group of patients, the advanced trauma life support guidelines, the new guidelines, are saying that in the elderly, we have to have a lower threshold for doing a CT scan, because I've already told you that the only thing typical about the elderly is that they're atypical. So they might not present in the same way. That's why we end up scanning them more often. And these categories have been highlighted, especially if they're diabetic, if they have chronic obstructive pulmonary disease, if they have ischemic heart disease, if they have coagulopathy, if they have cirrhosis. And any of these conditions is associated with a twofold increase in mortality. That's why in elderly, be careful. Now, so I'm going to now come on to last few slides. What is wrong with this statement? Dr. X, this 58-year-old man with a head injury has a blood pressure of 90/60. We are managing his head injury conservatively as advised. What is wrong with this statement? Why does that not fit in? A 58-year-old man with a head injury and his blood pressure is low. If you're a good, clever doctor, what will you be thinking? By the way, I started my lecture about 10 minutes late, so if it's okay, I might just run on for another 5 to 8 minutes, if that's okay. The reason this is not correct is that the head injury per se should not be the cause of hypotension. In other words, when you've got a trauma patient with a head injury and hypotension, you must be looking for another cause for the low blood pressure, whether it's a bleed somewhere else or something else. Because normally, remember, signs of intracranial hypertension are that your blood pressure goes high, not low. So just to bear that in mind as well. So if you see someone with a head injury and a low blood pressure, look for a cause of bleed somewhere else as well. Delayed diagnosis. Anyone who takes drugs and alcohol, they'll present in an atypical manner. So always dipstick the urine and think about cocaine and other drugs. Now, this is known as the trauma triad of death. These are the things which kill you in trauma. Hypothermia, we've covered that already. Every 1 degree drop in body temperature, your clotting cascade goes missing. Acidosis, coagulopathy, and up to 20 to 25% of patients who present to the emergency department are already coagulopathic because they've bled so much. But because they're young and fit, they can keep the blood pressure up, especially children, because they can keep the blood pressure up for a long time and then they suddenly drop. So let me answer my questions that I gave you, and then I'm going to finish the lecture in the next 4 to 5 minutes. Who has the highest mortality from trauma? Probably worldwide. It's the elderly, because they don't have the same reserves. What is the mechanism of injury which causes this? Fall from a standing height. They don't need to fall from the top of a building. Elderly people can have severe mortality falling because they're osteoporotic. They break easily. What proportion of rib fractures are missed on it? 50%. I've mentioned this before. What is the main prognostic factor in chest injuries? Pulmonary contusion. We know if you've got multiple rib fractures and you've damaged your lungs, mortality can be very high. So that's why we've started to give these people what's called a local regional block, like a serratus anterior block. And the patients feel great, and that has lowered the mortality significantly because we scan these patients and we can see what the problem is. This is a cardiac arrest, and when we did a thoracotomy on a patient who'd been stabbed, and he survived. This is just a joke, so let's move on. So I will finally leave you with what we do in the emergency department. A for airway. I don't know if you can see, but this elephant, this is from one of my friends who's a veterinary surgeon in Africa. And this is the A for airway. So remember, airway is very important, okay? You can see a twig, and this patient was having an operation. He survived. B for breathing, with oxygen connected. This is a leopard being intubated. C for circulation. This is a giraffe which had a cardiac arrest. And this is my friend Jonathan Cranston, who's jumping on the giraffe because the giraffe's heart is very big. So that was a cardiac arrest. And apparently this giraffe survived as well. So remember, airway, breathing, circulation. And I will finish there. And I will take any questions if there are any. And if anybody wants to email me, you can either email the organizers at BIMCO, or my email address is my name, Zul Mirza, all one word, ZULMIRZA, at hotmail.com. zulmirza@hotmail.com. I will finish my lecture now, and I will take any questions. Thank you for listening to me.
Thank you so much, Dr. Zul, for your incredible presentation as always. We are so pleased to have you here. We have a first question.
Okay, so first of all, I'm really grateful for your presentation. It was really amazing, and the topic you have presented was really great one. And I just have one question, because I'm a student of Bukovin State Medical University myself, and I wanted to talk more about thrombocytopenia as a condition, especially when it comes to patients who come through chemotherapy. So in terms of some major traumas, how can we tackle these conditions in those patients?
I can't hear very clearly, so I just heard something about thrombocytopenia. Is that right?
Yeah, right. Because some patients, they have this
Yeah.
condition due to
Yes.
chemotherapy. So how do we tackle the patients with this condition?
Okay, I mean, the first thing to do is that now, certainly in the UK and stuff, I think you've got to get the hematologists involved in this as well. So whether they need platelets as well, et cetera, when you do, what happens is when you have a major hemorrhage protocol, that will include either FFP, platelets, et cetera, but always involve the hematologists early in this. And they'll be able to tell you what the proportions of red cells are, what you can do for them, and if they've got any comorbidities. So always involve the hematologist, and they might need platelet transfusions, etc. But remember, the number one cause is the bleeding. So you've got to stop the bleeding first. Obviously, you give them the blood and stuff, but stop the bleeding. But involve the hematologist, because they will tell you the proportions to give. Thank you for that question.
Thank you so much. Yeah, we have another question.
Yep. I wish I was there. I can't see anyone. I can see a blank screen.
Hello, sir. Myself, Muhammad Sahil. I am from Bukovinian State Medical University. And sir, I have one question that in your presentation, you told about chest decompression from second intercostal space and another second approach from the triangle of safety. So I have a question that if patient come in emergency condition, which approach would be more good for doing chest decompression? As if we do from second intercostal space, it would be it would be challenging for us, like we can damage major vessels or subclavian vessel. And if we do chest decompression from triangle of safety, it can damage, like if the patient is with the altered anatomy and traumatized patient, it would be difficult for us. So which approach would be more good for this?
Yeah, I think that's a good question, but the best way to answer that is whatever you're comfortable in doing, and that is important, because you have to change the scenario according to the thing. So wherever you've got easier access and you're confident in doing it, you shouldn't carry out any procedures that you're not comfortable in carrying out. So you can go, obviously the second intercostal space is associated with great vessels and damage as well, but you've got to go according to what you can access, which part of the body, because you might have a lot of injuries on that side as well. So you've got to use your common sense and the clinical scenario. So whatever is the safer area, the easy access area, and your clinical experience. Thank you for that question.
Thank you so much. Does anyone has more questions? Yeah, one last question.
Hello, dear Professor Zulu Mirza. It was
Hello.
really interesting to hear your lecture. Thank you so much. So my question is, how do we actually improve long-term functional outcomes in polytrauma patients? So it was more about
that's a very
rehabilitation.
that's a very good question, actually. So one of the things that we're doing, the first thing to say is that the best way to improve long-term complications is to get everything right at the beginning. And that's important. That's where we talk about making the diagnosis and reducing the acidosis and all of those things. One of the biggest problems occurs with head injuries. And this is really important to maybe have a head injury clinic and physios and neurologists, involved in neurologists, the psychological aspects as well, because concussion, post-concussional syndrome, and long-term psychological issues. So if you have a dedicated service for head injuries as well, that's been shown to improve morbidity in the future. But the best treatment for long-term problems is to diagnose early and treat early. Thank you for that question as well.
Thank you so much.
I'm sorry I'm not there. I'm missing all of you guys, so maybe next year.
Thank you so much, Dr. Zul. We miss you as well, and we really hope to meet you in person finally in Chernivtsi after 6, I guess, or 7 years. Yes, thank you so much. Give a round of applause for our Dr. Zul.
Thank you.
Thank you so much.
Bye-bye.
And we proceed to our third lecture. І дякуємо доктору Зулу за таку змістовну цікаву презентацію. Ми переходимо до нашого третього спікера. Це є професор Рут Кіршнер-Германс із Бонну, Німеччина, яка сьогодні представить лекцію на надзвичайно важливу тему «Why do patients with spinal cord injury need neurology to survive and lead a good life». Ця лекція проводиться за підтримки громадської організації «Буковинський оберіг», і ми висловлюємо щиро подяку за їхнє сприяння в її організації. We kindly invite to the stage Professor Ruth Kirchner-Hermann from Bonn, Germany, from Johanniter Neurological Rehabilitation Center, Godesha. Okay, perfect. Yeah, with the topic, why do patients with spinal cord injury need neurology to survive and lead a good life? So Professor Ruth, the floor is yours.
Пару слів хочу дозволити собі презентувати нашого наступного лектора. Нашого наступного лектора. Пані Рут – великий друг України. Вона дуже відомий нейроуролог. Вона займається саме нейроурологією, тобто ті ситуації, в яких пацієнти мають важкі неврологічні порушення. І, відповідно, щоб ви розуміли, що люди, які не рухаються, не ходять з неврологією, вони не помирають просто від того, що вони не ходять. Більшість з них помирає від того, що у них виникають інфекції сечової системи. Тобто якраз це є та галузь, в якій пані Рут, вона є експертом Європейської асоціації урологів, вона приймала участь в написанні рекомендацій, вона проводить курси, тому це всесвітньо відомий спеціаліст саме з такого вузького направлення, як нейроурологія. Але, на жаль, в наш час в Україні таких пацієнтів більше стає, враховуючи бойові дії, і цивільні, і військові. І тому пані Рут з початком військових дій, вона активно приймає участь в встановленні реабілітаційного центру в Рівненській області в Кливані. Зараз це найбільший центр в Україні, який займається саме такими пацієнтами після певних пошкоджень спинного мозку, у яких є порушення нервової системи, і, відповідно, цьому буде присвячена її лекція. Будь ласка, пані Рут.
Yeah, thanks. I didn't understand one word, but I hope he only told nice things. First of all, I'm a urologist. So I'm a urologist, and all what a urologist is concerned about at least if it's a functional urology, is a bladder. So what I'm talking about is a bladder, and I'm concentrating on bladder in spinal cord injured patients. So do you all understand me?
Where is? Here is. I will.
Okay. So yeah, you have to move forward too.
Okay.
Prava Knabica.
Право. Окей, щось. Sorry. Sorry, please.
You see, this is me in my younger age, and I'm a clinician and a researcher for neurourology at the Neurology Rehabilitation Center Bonn-Bad Godeshöhe, and I'm affiliated with the University Clinic of Bonn, and I occupied a university professorship from up to 2023. And now I'm reducing a little bit my clinical work, and that gives me the time and to be here and to visit you because, you know, I'm always working with with the function of the bladder. And my first experiences in Aachen with spinal cord injuries were all the veterans from the Iran-Iraq war. So when the terrible war, the full-blown war 2022 started here, I thought maybe there is a need to do some training and some help. So, and I also, you know, I kind of, my expertise grew first about pelvic floor and losing urine while sneezing and coughing, or by running too often to the bathroom. And then I specialized more on aging bladder, which brought me to America, 1995 to 97. And then finally, neurourology. Next slide. So what is the aim of neurourology? And the most important thing, and that's also my motivation to come here and to visit other rehabilitation centers like I did in Lviv, and I'm going to Vinica and to Dnipro. Because the aim of neurourology is prevention. We want to prevent that the kidneys fail. We want to preserve renal function. We want to prevent urinary infections, at least urinary urosepsis. We want to achieve sufficient bladder storage capacity. If possible, we want to restore continence, but that is not our first goal. But it is, of course, also we want to improve quality of life.
I will say something.
Oh, yeah.
Коротко відносно цього слайду, значить, тобто проблема головна при неврологічних порушеннях, якщо порушується функція сечової системи і сечові міхури не спорожнюються, нирки не працюють нормально. І головна проблема, головне питання, яке ми повинні вирішити, збереження функції нирок, щоб вони не втрачали функцію, щоб не було ниркової недостатності, щоб сечовий міхур міг спорожнюватися і по можливості збільшити його ємність, тому що при цьому дуже часто вона низька, і відповідно по можливості відновити сечопускання і, безумовно, покращити якість життя таких пацієнтів, які, ви розумієте, на жаль, в більшості випадків ми не можемо відновити повністю функцію сечової системи, але зробити так, щоб якість життя була більш-менш достатньою.
So I know I'm working in a very small field, and I know maybe one or two of you I can excite for neurourology. But everyone who is working and who will see patients with spinal cord injury, even as a primary doctor in the country, should know some principles. And we should look back to the beginning of neurourology. Sir Ludwig Guttmann, and he lived in England 1899 until 1980, he was the first who realized that he revolutionized the therapy of spinal cord injured patients. And it was this when he was 18 years old, he was working as a volunteer and a nurse in a mining clinic in England. A worker was admitted to the ward. He is paralyzed after a mining accident. And a nurse said to him, "You don't have to worry about him. He'll die in a few weeks." 5 weeks later, the paralyzed friend is dead, dying of urinary tract inflammation and wound fever. And I can tell you, this story is now a little bit better. Patients all get a catheter, so they don't die in 5 weeks. But a majority of patients with spinal cord injury will die within 5 and 7 years. And that is the main message, the main take-home message, that is not necessary. And we have lots of other options, and about those options I want to talk to you. And please keep in mind, Sir Ludwig Guttmann is also the founder of the Paralympics. He was the first who rented a big Boeing or something and had, I think, 30 wheelchairs in this big airplane and flew them to Rome, which is the first Paralympics we know of.
Ну, більшість тексту тут написано. Коротко, це сам Людвиг Гутман, це була перша людина, яка зацікавилася цією проблемою. І саме головне, що ви повинні пам'ятати, що правильний менеджмент сечових шляхів дозволяє зменшити смертність з 90% до 10%. Тобто це ті цифри, яких можна досягнути за рахунок тих методів лікування, про які сьогодні буде говорити пані Рут. Ну і крім того, він засновник Паралімпійських ігор, який в плані першим це організував, орендуючи ці візки для інвалідів, які він віз в літаку. Please.
And our mission is also part of the WHO. It's to reduce mortality and improve quality of life in patients with spinal cord injury. And on the picture there, you see a friend of mine. She's working in a company I know, and they are I think the German the German champions of wheelchair dancing. And so I think sport can really improve quality of life, and in order so that they can do it, we have to care for their bladders.
Ну і прикладом цього може бути німецький чемпіон з паралімпійських танців. Ви бачите танці на візку, що показує то, наскільки можемо покращити якість життя таких пацієнтів.
So when we think of the bladder, we always think of how to void, because we're thinking of a... But as a matter of fact, 90% or 95% of the day, our bladder is calm and is a good storage organ. Otherwise, we would all go to the toilet now. So the bladder has his main task is storage, then of course perception, we have to know when we go to the bladder, and then of course the emptying.
Головними фазами функції сечового міхура є накопичення сечі, є відчуття при цьому і випорожнення. І ми всі зараз знаходимося в фазі накопичення, тому що інакше, якщо б цього б не було, ми всі б або були б вологі внизу, під нами щось би було, або пішли б в туалет. Okay, next.
So, let's talk about the storage phase. First is, of course, the bladder expands, stays calm, and the sphincter is contracted. Otherwise, we would be incontinent.
Під час накопичення сечі, сечовий міхур дитинозу повинен бути розслабленим, він повинен зберігати цю сечу, і ви при цьому не повинні відчувати ніяких покликів до сечопускання. Нормальна ємність сечового міхура, бачимо, біля 500 мл.
But during the voiding phase, the bladder contracts and the sphincter relaxes. And that's important, that we have a low resistance emptying that the bladder completely empties. Let me see. That the bladder completely empties and that the micturition is controllable, so that we have enough time to go to the bathroom.
Фазу скорочення сечового міхура, фазу сечовипускання, відповідно, відбувається скорочення стінки сечового міхура. Дуже важливо, щоб це відбувалося з низьким тиском, тобто коли ви мочите, щоб не було великого тиску в сечовому міхурі, і ви могли контролювати сечовипускання.
But everything is controlled by our brain and by the nerves, the afferent and the afferent nerves going through the sacral micturition center, S2 to S4, to the brain, and then through the afferences who initiate the voiding. And then we know, oh, we are on the bathroom, on the toilet, now we can void. And if this all plays together, and by the long way from the brain to the bladder, you know that a lot of things can be wrong. And actually, our bladder wants always to void. But there is a supra center in the brain who prevents this constant urge to void.
Відповідно, ми маємо декілька центрів сечовипускання, які між собою повинні бути чітко взаємозв'язані, і дуже багато чого може піти не так в цьому ланцюжку від центрального центру до, власне, сечовипускання. Okay.
And you have to know that nearly all types of spinal cord injury lead to a disturbed bladder storage, up to 90%. And not only quality of life, but I already said, above all, life expectancy depends on good neuro-urological care. You can also say urological care, but the problem why I always mention urological care, that many urologists, and I think in Ukraine it's also, you have the surgeon and you have the people who are not doing surgery. And the neurourology is mainly doing diagnostics and therapeutical things. And in Germany, they would then also do the surgery. But you have to turn to a urologist who also is experienced in bladder dysfunction.
До 90% всіх пацієнтів, які мають порушення спинного мозку, мають проблеми з сечовипусканням і сечовою системою. Відповідно, нейроурологія – це саме та наука, це саме ті спеціалісти, які приймають участь в лікуванні цих пацієнтів. В Німеччині так само проводяться операції у таких пацієнтів, але в усякому разі лікарі повинні розуміти, яким чином, в принципі, цих пацієнтів вести.
So you know already there are storage functions and voiding functions. So the storage can be dysfunctional and the voiding can be dysfunctional. As typical problems of bladder storage function would be like you have an overactive or small capacity bladder. You might know some elderly who always have to go to the bathroom, or an insufficient bladder closure that you leak either before you reach the toilet or that you have leakage when you cough and laugh and other things. And we have voiding dysfunctions. That sometimes is true with overstretched bladder, atonic or hypotonic retrusor. We will see that also this can happen after spinal cord injury. And you can, of course, have an overstretched and not functioning voiding if you are elderly, a man, and have a intravesical obstruction caused by BPH, by an enlarged prostate. But the most important thing in spinal cord injured patients are the detrusor sphincter dyssynergia. We speak about detrusor sphincter discoordination when it's just a habitual thing. But if it is a neurological cause, then it's detrusor sphincter dyssynergia.
Фазу накопичення сечі, в якій, я сподіваюся, всі ми з вами знаходимося, Головною проблемою може бути те, що сечовий міхур скорочується надмірно. Відповідно, це ми можемо бачити дуже часто, примір, у літніх жінок, які шукають туалет, терміново їм треба піти в туалет. Це якраз та ситуація, коли є скорочення сечового міхура, відповідно, так званий гіперактивний сечовий міхур виникає. Фазоспорожнення при сечовипусканні – це те, що більш типово для неврологічних пацієнтів. Найбільш головною проблемою є те, що він може бути або сечовий міхур, або може не скорочений, буде перерозтягнутим, або та ситуація, коли виникають проблеми з обструкцією на виході. Прикладом такого може бути, приміром, чоловіки старшого віку, у яких є проблеми з простатою. Ну, а у неврологічних пацієнтів частіше всього виникає дискоординація вітрусного сфінктерного апарату. Тобто, коли вітрус скорочується, приміром, а сфінктер ще не розслаблений. І тоді виникає дуже великий тиск в сечовому міхурі, що пошкоджує нирки, що приводить до інфекцій і до інших проблем.
So on the left, you see a uroflowmetry chair. It's a micturition chair, and it measures how the flow is. You see the curves. You see the curves down there. But of course, not everybody will have a uroflowmetry. I learned when I was in Harvard in America, and the geriatrician, he said you only need your ear. Put your ear when the patient voids, and then you see if it's a good stream or if it's dribbling and a low stream. So that could also easy can then, or by asking the patients, do they void in one row or do they have an interrupted stream?
Урофлометрія – це приклад урофлометричних кривих. Саме простий метод дослідження сечопускання, спонтанного сечопускання. Ми бачимо в такому кріслі воно проводиться, або може стоячи. При нормальному сечопусканні цей графік, він має такий вигляд кривої, по типу такої звіноподібної кривої. Якщо дискоординовано, ми бачимо на цьому графіку деякі піки, які говорять про те, що є проблеми з координацією функції сфінктерного апарата і скороченням детрузора.
You all have access to ultrasound. So in addition to the uroflowmetry, you can check, or you should always check, if the bladder is really empty after voiding. So, and if they say they void in a good stream and they have no residual urine, you can be happy, and this patient most likely doesn't need a urologist.
Крім, власне, урофлометрії, саме простий метод – це визначення залишкової сечі. Тобто після сечопускання, якщо пацієнт не має залишкової сечі, ви можете бути щасливі, ну і він повинен бути щасливим. І, відповідно, в цій ситуації, можливо, йому не треба якоїсь специфічної урологічної допомоги.
So that was easy. But now we have to discriminate the different types of neurogenic bladder dysfunction. First is, of course, the brain with the pontine micturition center, and we call those lesions suprapontine. Then we talk about, and they often have neurogenic detrusor overactivity. That means the bladder always contracts. That is, of course, especially true in brain-injured patients, and also in patients with encephalitis and dementia.
Okay. Тепер ми поговоримо про різні варіанти нейрогенних проблем з сечопусканням. Перший варіант – це так званий надпонтинний, коли виникає нейрогенна гіперактивність детрузора. Тобто принципово основа функціонування сечового міхура полягає в тому, що з понтинного центру, з кори із понтинного центру виникають гальмівні впливи на детрузор. Тобто коли немає цих гальмівних впливів, детрузор починає надмірно скорочуватися. І виникає так звана нейрогенна гіперактивність. Найбільш типово це для травм голови, для енцефаліту та для деменції. Це надпонтинний варіант порушення функції сечового міхура.
The next is the spinal part, and that's, of course, above the sacral micturition center S2, S5, and that is the main area where the trauma is in most spinal cord injured patients, and it's also happening with multiple sclerosis. And this is a case which is most dangerous, when the detruser is overactive, hyperactive, produces a lot of pressure, and the sphincter closes.
Наступний
You have
назад.
to go back.
Наступний – це спинний варіант розладу. Це найбільш типовий, тому що він включає в собі практично весь спинний мозок до S5, до центру сакрального центру сечопускання. Відповідно, тоді виникає гіперактивний детрузор, тобто він сильно скорочується, і в той же час сфінктер не розслабляється. Тобто ми маємо скорочення детрузора, закритий сфінктер, і відповідно це приводить до того, що дуже сильно піднімається тиск в сечовому міхурі, і саме тоді виникають ці рефлюкси в нирки, і найбільші проблеми з нирками і з сечовою інфекцією. Найбільш неприємні і найбільш небезпечні для пацієнта варіанти порушення неврологічних розладів.
And then on the lowest part is suprasacral, so that means the sacromicturition center is still intact, and the subsacral lesions. They lead to a detrusor hypoactivity. So there's no pressure in the bladder, but they cannot void because they have no pressure, or they are incontinent if the sympathicus is always also injured. We talk about cauda equina injuries and also these nerves which are in the pelvic floor but out of the spinal cord.
Ну і третій варіант – це периферичний варіант порушення, це так званий субсакральний, коли порушуються нерви, які вже йдуть, власне, від сакрального центру сечопускання до сечового міхура. Відповідно, це приводить до того, що він не скорочується, він стає дуже великим, гіпоактивним, і це приводить до того, що пацієнт або не може взагалі помочитися, або, якщо порушується паралельний сфінктерний апарат, відповідно, воно постійно виникає постійне нетримання сечі, і просто сеча в сечовому міхурі не утримується. Як правило, це порушення кінського хвоста, травма тазу, цукровий діабет, післяопераційні різноманітні ситуації. Тому такі пацієнти, вони мають свою клініку.
So an easy picture was made by Helmut Madersbacher from Austria, and he kind of had as a symbol, when you see a very thick line, that's an overactivity. If you see a very thin line, it's an underactivity, and green is normal. So the suprapontine reflex bladder is here in the first, and which is the most important and most dangerous case is, of course, a spinal reflex bladder. If you have a hyperactive bladder and a hyperactive sphincter. And what do we want to achieve? Something like an atonic or a bladder which is kind of relaxed well, but we want or we don't mind a good sphincter, because that, of course, improves quality of life if you don't leak.
На даній ситуації схематично переведені форми порушення сечопускання. Там, де товста лінія, відповідно, це надмірне скорочення, там, де тонко, це заслабе скорочення. І, відповідно, якщо ми говоримо про найбільш небезпечні, це якраз перша, друга картинка, коли є сильне скорочення детрузора і, відповідно, великий тиск в сечовому міхурі. Чого ми хочемо досягнути принципово? Це зменшити тиск в сечовому міхурі, щоб він не скорочувався сильно, це тоді запобігає порушенню функції нирок. Ну і по можливості тримати сечу, щоб не було проблем з нетриманням сечі.
So the first thing we see is a suprapontine reflex bladder. And you see here a photo of my second out of 10 grandchildren. And in him, it is cute that he can't control his bladder and constantly void. Now he's 7, so he is toilet trained. But the same kind of, and in an infant, it's the bladder is working okay. They never have residual urine, and they just don't know when and where to void. And but kind of the same condition is true after brain trauma.
Якщо говорити більш детально про супрапонтинний рефлекторний сечовий міхур, це та ситуація, коли сильно скорочується сечовий міхур, і тут професор привела фотографію одного свого з онуків, у якого так само була схожа проблема. У нього не було цих неврологічних порушень, але принцип той самий. У дітей дуже часто, ми знаємо, є часто сечопускання, нетримання сечі, і це елемент дозрівання нервової системи, це певний фізіологічний момент. Ну, такі самі принципи функціонування будуть у тих людей, які мають неврологічні порушення.
So now we come to the spinal reflex bladder.
Next one.
Yeah, next one.
Okay. Where is it? Okay.
So, and the spinal reflex bladder can, of course, happen durch car accidents, but can, of course, also happen in war times. And here we have a totally different situation. The brain functions, but the signals of the brain don't go through to the micturition center. So there is no control of the bladder reflex. So although the bladder in itself is not the coordination is basically the coordination of bladder and sphincter doesn't work.
Ну і найбільш небезпечні, як попередньо вже говорилося, це так званий спінальний рефлекторний сечовий міхур. Часто буває після травм мотоциклістів, але в той же час і після військових травм, безумовно. Це та ситуація, коли, відповідно, одночасно сильно скорочується детрузор, і сфінктерний апарат, він так само нормально не працює, і, відповідно, це приводить до великого тиску в сечовому міхурі і відповідних проблем з сечовим міхуром.
Maybe you can go once again back. No. Okay. You see, when in the high bladder, I see it in my animation, the urine can go back to the kidney. And what's also important to know, even if you don't see a reflux in X-ray, when the bladder has high pressure, the kidneys can't work properly. In some patients, the kidney gets destroyed faster, in others later, but they always will be damaged, because if there is a high pressure, the kidney will be disturbed even if there is no reflux.
Ну і головна проблема не в самому сечовому міхурі, а в тому, що нирки при цьому не можуть нормально працювати. Рано чи пізно, коли є великий тиск в сечовому міхурі, нирки перестають нормально працювати, вони не можуть виділяти сечу. Відповідно, ниркова недостатність у таких пацієнтів є неминучою, якщо їх адекватно не лікувати. Анімація пішла. Окей. Оце рефлюкс, про який тільки що говорилося, да? Рефлюкс нирки.
And now I don't know if you see that on the graph so clearly. We have to talk about the spinal cord, because the vertebrae and the spinal cord, there are some variability. So don't confuse. That's why we never can be exact where the nerves are damaged. And especially tricky is the place between TH12 and L5, because that is the region where the spinal cord ends and the filia leave the spinal cord. And you can see here that we have to discriminate the upper motor neural lesion. The upper motor neural lesion are the nerves within the spinal cord. The lower motor neural lesions, as we find in conus cauda and equina lesions, that are the nerves which are, then the nerves are damages which directly go to the muscles, to the end organ.
Назад. Значить, ну і безумовно важливим є розуміння анатомії спинного мозку, тому що від початку від Т12 до L5 ми бачимо, це то місце, де починається кінський хвіст, і відповідно залежить від того, якщо це порушення верхніх нейронів, це вище L3, там одне питання, якщо нижні нейрони, відповідно це вже ураження кінського хвоста, це та ситуація, коли власне уражаються самі нерви, які безпосередньо йдуть до сечового міхура і інших тазових органів.
And even with T12, some of the nerves already go out of the spinal cord. And so when you hear he has a lesion sub L3, it doesn't mean that it always has to be an upper motor neural lesion.
Після Т12 нерви вже частково покидають спинномозговий канал, і відповідно не завжди при порушеннях у цьому місці ми будемо мати неврологічні порушення відповідні.
And to discriminate the upper and the lower motor neural lesion, that's where urodynamics help.
І саме уродинаміка потрібна для того, щоб розуміти цей рівень пошкодження нервів і відповідно виробити лікувальну тактику в цих ситуаціях.
That's a picture out of my clinic with my colleague Anke Jekyll. So, and we already said the high blood pressure and but you can stay with it. A high blood pressure and the low compliance. Low compliance means if the bladder is contracting so much and the bladder is not distending without pressure. Like if my bladder fills, the pressure in the bladder stays the same. And the only way to detect how the pressures and how the compliance in the bladder are is by measuring this pressure.
Ну і головна проблема в тому, що ми не знаємо, які тиск в сечовому міхурі, про які ми вже з вами багато говорили. Єдиний варіант дізнатися, що в сечовому міхурі відбувається, це провести специфічне уродинамічне обстеження, яке дозволяє нам диференціювати різні варіанти порушень функцій сечового міхура.
So, and now I come to urodynamic investigation, and I'm very glad that there is one machine in Klevan already working. There will be 2 other machines in Vinica and in Dnipro, and we keep our fingers crossed that although the US aid help is now, I don't know, but that Lviv has also a urodynamic machine and a team who can work it. So, what do we do? How do we do urodynamics? Just to give you an idea. We have a catheter in the bladder and we have a catheter in the rectum. And because, next slide, or maybe you
Next.
No, or you translate first.
Коротко про динаміку, значить, тобто це обстеження, яке полягає в тому, що в сечовий міхур вводиться один катетер, в пряму кишку вводиться інший, для того, щоб віднімати тиск, який створюється в черевній порожнині, тому що він напряму впливає на тиск в сечовому міхурі. Але тиск в черевній порожнині, він ніяк не залежить від сечового міхура і навпаки. Відповідно, цих 2 катетера, вони ті, що реєструють тиск, і по їх різниці ми розуміємо, що робиться чисто в сечовому міхурі, який тиск там створюється детрузором.
So we measure the pressure in the bladder and the pressure in the abdomen, but we subtract the abdominal pressure from the vesical pressure to know about the detrusor pressure, because that is the pressure we are worried about.
Тобто, то, що вже говорилося, що ми повинні розділяти тиск в черевній порожнині, абдомінальний тиск, і тиск детрузора, який, власне, створюється тим, що скорочує стінка сечового міхура, для чого, відповідно, нам потрібні таких 2 датчика.
And here we see how a urodynamic looks like. The blue line is the vesical pressure, the red line is the abdominal pressure, and the turquoise is the calculated detrusor pressure. And below then, the yellow line, you see how the bladder is filled, and the kind of brown line is the voiding phase. So that is kind of a normal urodynamic.
Під час уродинаміки ми маємо тиск в сечовому міхурі, верхня лінія, наступна лінія червона, тиск в черевній порожнині. Назад воно щось переключається. Тиск в черевній порожнині. Відповідно, хвилиночку. Відповідно, нижня третя лінія, така блакитна, це є різниця між цими тисками, це чистий, справжній тиск, який створюється детрусом. І далі внизу маємо ще криві, це об'єм рідини в сечовий міхур і сечопускання, якщо воно відбувається. І внизу ще електроміограма ми бачимо.
So it's the subtraction of the abdominal pressure from the vesical pressure, which gives you the detrusor pressure, which determines then our therapy.
Ну, то, що ми говорили. Далі тиск детрусорів, він визначається допомогою із загального тиску в сечовому міхурі, забирається абдомінальний тиск, і ми маємо чистий тиск детрусора.
And next.
Okay.
So now I only will give you some examples.
Декілька прикладів.
So this would be these little spikes you see in this turquoise line already signal you that something is wrong with the bladder.
На цих кривих ви бачите оці от підйоми тиску, це значить, що щось не так з сечовим міхуром. Ми бачимо великі підйоми, це кашель, ми просимо пацієнта покашляти, щоб контролювати розташування цих датчиків, а от далі от підйоми тиску, це говорить про те, що відбувається скорочення власне детрусора.
And this is a typical, next please.
Next. Okay. Next. Okay.
This is a typical sign of phasic detrusor overactivity you will find in patients with upper motor neuron lesion.
Значить, на даному слайді ми бачимо типові приклади оцих скорочень детрусора, це гіперактивного детрусора, тобто коли ці піки тиску виникають. І це якраз та ситуація, яка типова для оцих спінального рефлексу, який є найбільш небезпечним для таких пацієнтів.
And you see that there is urine coming out in this pinkish line, but this is not a micturition, that is just leakage. Don't mix that up.
І відповідно ми бачимо в кінці написано міксія, але в принципі це не міксія, це є нетримання сечі, тобто це не то, що пацієнт хотів помочитися, за рахунок того, що підвищується тиск і сеча просто видавлюється так по-простому з сечового міхура.
Next example. So next example is a typical subsacral lesion, also lower motor neural lesion. There is no reaction of the detrusor. And actually you find that also after, if you have an acute spinal cord injured patient, you will find this picture in nearly all patients because the spinal cord first goes in a so-called spinal shock, and there's nothing. And the detrusor overactivity starts about 6 weeks to 3 months.
В даній ситуації ми бачимо інший варіант, так званий атонічний детрусор. Це тоді, коли ми бачимо при наповненні сечового міхура, але немає ніякої реакції, тобто він не скорочується. Це може бути або та ситуація, коли виникають ці порушення тазових нервів, про яку ми з вами говорили, або це ситуація типова для так званого спінального шоку, який виникає протягом десь приблизно 6 тижнів після порушення спинного мозку, після травми хребта. Спочатку виникає спинальний шок, а вже після нього, через 6 тижнів, виникає цей гіперактивний сечовий міхур.
That's why it is good that the urodynamics machine, which are already installed, are sitting in rehab centers who care for spinal cord injured patients, and it is not so much a problem that maybe in acute phase you don't have an access to evaluate the bladder function.
Відповідно, ми маємо аеродинамічні центри, які дозволяють виявити ці аеродинамічні порушення. І, можливо, в цьому плані навіть добре, що спочатку, перші цих пару тижнів, пацієнт не має таких гіперактивних скорочень, тобто це краще для нього.
But what you never should do is clamp the catheter in the hope that you can train the bladder. You can't train the bladder.
Але одною з помилок є те, що коли ви пробуєте поставити катетер, тренувати сечовий міхур, так зване тренування сечового міхура, на жаль, ви цього ніколи не досягнете, тому треба це розуміти.
So this is the other case. This case, the pressure is constantly rising, and that is also a typical phase. You don't have any reflux. You see that in the bladder picture outside, but the kidney will still be harmed because the bladder can't distend without a pressure rise.
Інший приклад – це так званий низький комплаєнс. Комплаєнс – це, скажімо так, пластичність сечового міхура. Тобто, по-простому, попробуйте, щоб такий приклад, попробуйте надути грілку, звичайну грілку. Ви не дунете, не зможете надути, вона лопне. Або вона лопне, або ви нічого не зробите. Але кульку, яку ви надуваєте на параді, ви зможете надути, тому що вона пластична. То саме сечовий міхур. В даній ситуації ми бачимо ця блакитна лінія, постійний рост тиску в сечовому міхурі з його наповненням. Тобто нема цих скорочень типових для гіперактивності, але він постійно піднімає тиск, і так само це погано, тому що цей підйом тиску так само негативно впливає на нирки.
So in the other cases, I don't have to explain explicitly, but it's always, and the pressure should be always in a normal range, also in comparison to the flow.
Даний приклад – це так звана інфравезикальна обструкція, коли порушується прохід сечі по уретрі. Відповідно, ми бачимо, що навіть коли хворий може помочитися, він спочатку не може помочитися із-за того, що виникає ця проблема.
And there's one other topic I really want to raise the attention of everybody, whether they care for spinal cord injuries or if they just have a friend or a neighbor who is suffering from a spinal cord injury, and that is autonomic dysregulation. And that's especially dangerous for patients with an injury above T6, T7. That's about the range. And what are the autonomic dysregulation? The brain can't regulate the blood pressure any longer. So there is something below the lesion happening, and the pulse goes down, the brain tries to overregulate, and the blood pressure goes down, and the bowel goes the pulse goes down and the blood pressure rises.
Ну і дуже важлива і дуже небезпечна ситуація, так звана автономна дисрефлексія. Це та ситуація, коли виникають високі пошкодження спинного мозку, вищі Т6, Т7. В тій ситуації при наповненому сечовому міхурі або наповненому кишечнику, за рахунок того, що мозок якось старається врегулювати цей стан, і він не може це зробити, виникає, відповідно, дуже сильні соматичні проблеми, відповідно, підвищується тиск, вплоть до того, що це може бути життєво небезпечним, і хворий може мати серйозні життєві проблеми за рахунок наповненого сечового міхура, ну, що треба розуміти так само в таких ситуаціях.
And how do I see that? When I'm not a doctor, just a neighbor, there are the so-called Goodman. We remember Sir Ludwig Goodman, who kind of invented neurourology, and the Goodman signs are like getting pale, having some sweat, trembling, and not feeling so well, headache. All these signs in a spinal cord injury patient have to make you alert, especially when you do some kind of manipulation of the bowel or the bladder, like with catheterization, and also with defecation, or if you have to empty the intestines.
І відповідно ми маємо так звані ознаки Гудмана, тобто це та ситуація, коли хворий з порушенням спинного мозку починає блідніти, потіти, у нього починається нервовий тік. Відповідно, це типово для тих моментів, коли переповнюється або кишечник, або сечовий міхур, або ми робимо якісь маніпуляції на кишечнику. Відповідно, це може призвести до такої автономної дисрефлексії і вплоть до летального випадку.
And here is an example how rapid the blood pressure can rise. So that's why we always measure the blood pressure the same time as we do a urodynamic. And you see here the detrusor is completely flat. There's no pressure in the bladder, but the blood pressure rises vividly, and you have to teach the patients to look for those signs so that they can maybe schedule their intermittent catheterization for that, so that they empty the bladder, and that the carers also know this patient is vulnerable for an autonomic dysregulation.
Ну і це приклад такого пацієнта. Тобто ми бачимо, що верхні шкали, тобто верхні лінії, це наповнені сечового міхура абсолютно рівні, тобто немає підвищення тиску, але ми бачимо нижче різке підвищення артеріального тиску при наповненні сечового міхура. Пацієнт при цьому нічого не відчуває, він цього не розуміє. І відповідно в кінці ми бачимо введено синеньким, що різко знижується пульс, знижується насичення крові киснем, тобто це реакція, автономна реакція на таке наповнення сечового міхура, але він цього не розуміє. У них в лабораторії, де от я був, вони обов'язково в таких випадках підключають датчики тиску, підключають датчик пульсу і підключають, відповідно, оксигенацію для того, щоб розуміти, що немає таких проблем або вони виникають. Тому у таких ситуаціях перенаповнення сечового міхура може призвести до дуже негативних наслідків для пацієнтів з неврологічними проблемами.
And that's what we want to prevent. We don't want to see kidneys like that, because that is irreversible. And if you see a hydrated pelvis and you put like a stent, you see that here again, and if you put then a stent from the bladder through the kidney, you even harm the kidney even more. So, yeah.
Ну і в даній ситуації ми бачимо рентген, це ми бачимо картаз сечового міхурі, який поступає з сечового міхура ретроградно в нирку, нирка розширена, це приклад міхурово-сечовідного рефлюксу з виразним гідронефрозом, відповідно, що порушує функцію нирок. І як такий практичний момент, ми, приміром, при рефлюксі ми ставимо стенти в сечовід для того, щоб дати відток сечі, але проблема в тому, що коли сечовий міхур постійно дає такі тиски, наявність стенту навіть погіршує ситуацію, тому що сеча легше попадає наверх в ниркову миску.
And actually, in those cases, also urodynamic doesn't really help you, because the pressure is already in the kidney. The urodynamic of the bladder might look nearly normal because you oversee what's already happened. And that's, of course, then prevention is over. Then you have to go to treatment. You basically have to extend the bladder with intestine or find some other solution to at least save the kidneys. But that is difficult if things have gone already that bad.
Ну і, відповідно, в таких ситуаціях навіть ододинаміка не завжди допомагає, тому що ми бачимо, що при наповненні сечового міхура виникає рефлюкс, потім він збільшується, і на крайній правій картинці ви бачите, скільки порушується функція нирок. І в цій ситуації ододинаміка не дуже допомагає, тому що тиск весь йде якби в нирку. І тому в цій ситуації, коли у хворого така проблема з сечовим міхуром, ми повинні якимось чином або збільшити сечовий міхур, зробити пластичну операцію, або якимось іншим чином проводу допомагати цьому пацієнту.
These patients need lifelong aftercare. And of course, they are to 90% catheter dependent. Of course, we prefer intermittent catheterization instead of an indwelling catheter. And if an indwelling catheter, we prefer a suprapubic to transurethral catheter. But maybe you translate that first.
І нарешті пані тут хоче показати, яким чином ми повинні наглядати за цими пацієнтами. Перш за все, ми повинні знизити тиск сечового міхурі, про що ми з вами постійно говоримо. Це або за рахунок самокатеризації, або в деяких ситуаціях накладається цистостома, тобто накладається штучний отвір в сечовий міхур, для того, щоб був вільний вихід сечі з сечового міхура.
Yeah, so our guidelines say you should every year do a urodynamic checkup, renal function every 3 years. Creatinine is not sufficient. You have to diagnose more clearly. Cystoscopy every 5 to 10 years, because the indwelling catheters especially have a higher risk of having a very severe bladder cancer. And in addition, I think you have to work closely with the patient and their family. And under these optimal conditions, even paraplegics can achieve a life expectancy with little and no restrictions. And I can tell you that in the Swiss-German society, 60 to 70% also have a job. They have a job. They work. They are integrated in. They have a different life, but they have an integrated life with some kind of hobbies and also a job.
Відповідно, у таких пацієнтів ми повинні щорічно проводити аеродинамічне обстеження, діагностика функцій не кожні 3 роки, повинна бути цистоскопія кожні 5 або 10 років, тому що при використанні катетера можливо поява дуже агресивного раку сечового міхура, щоб його відповідно вчасно діагностувати, повинні робити цистоскопічне обстеження. Обов'язково освіта і інформування і пацієнта, і родичів відносно стану і того, як з цим відповідно жити. Ну і пані тут говорить, що приблизно 60-70% всіх пацієнтів з такими навіть дуже серйозними проблемами, вони мають роботу, вони працюють, безумовно, у них є обмеження, але вони живуть більш-менш повноцінним життям.
So, and I want to thank to everybody who supports me, of course, Irina Rudenko, who is, you see on the picture, who is the driver, and the project leader is Irina Godima, came from New York to support us, and also Rhythm Health and WHO. They support us with simultaneous translation, and of course, Jaroslav, who organized this meeting here, and I'm really, really grateful. And keep in mind, patients with spinal cord injury don't have to die. You have to do something. And of course, I have to thank Valerie.
Ну і в кінці наша шановна гостя, вона хоче подякувати всім, завдяки кому цей візит став можливим. Пані Ірина Руденко, Ірина Гудима, яка є представником Всесвітньої організації охорони здоров'я з Нью-Йорка, організатором конгресу і організації «Беріг», яка так само допомагає їй приїхати в наше місто.
Thank you.
Дякую за увагу.
Thank you so much, Dr. Ruth, for this incredible presentation. Maybe someone has a question? Oh, wow, perfect.
Thank you for this great information. My question is, in addition to catheterization, do you use electrical stimulation on the nerves to give the person a feeling of a full bladder? If so, which part of the nervous system do you stimulate depending on the cause, and how often should you do as electrical stimulation?
Very good question, because I know that is electrical stimulation. How do I say that? Its role is not as big and as good as we hope and we think of. I'm not so much in favor of it. There are 1,000 different ways of electrostimulation, but most patients, besides neurosacral modulation, where you do implants, I see unfortunately little role in electrostimulation. And how it works, that is a myth, since it works in some overactive bladder with no neurological case. It works in MS, sometimes even in Parkinson. And there has been one work by a colleague of mine from Germany that it would work if you do sacromodulation, but implanted sacromodulation when you do it right away. But since this was published maybe 15 years ago, and the practice has not kicked off, although we have all the possibilities to do it, I am still a little bit skeptical. And I say something, which kind of, before you spend a lot of money on electrical stimulation, don't, I think you have to be very careful not to spend too much money on something which doesn't work.
Thank you for answering.
Я трошки поясню, бо це така специфічна ситуація. Значить, мова йшла про електростимуляцію. Електростимуляція – один з методів лікування порушень функції нижніх стощових шляхів, коли частіше всього стимулюються специфічні нерви. Специфічні нерви, які допомагають скорочити сечовому міхуру. Але, на жаль, це пані Рут достатньо скептична відносно цього методу, тому що він не показав свою ефективність. Іноді він може допомагати при нейрогенному сечовому міхурі, при розсіяному склерозі, але до сих пір він не показав, що ті гроші, які в нього вкладаються, вони дають той ефект, який ми би хотіли би очікувати, на жаль.
And don't forget, symptoms is not the key thing. The key thing is to keep the pressure in the bladder down.
Perfect. Thank you so much, Dr. Root. Unfortunately, we need to finish our plenary session for today. If you want to ask some more questions to Dr. Root, I hope she will be open to them, like later on. We can ask you to make a common photo here and in front of the building, and then we will proceed to our lunch and to the workshops. Thank you so much. Дякую. Ми завершуємо на сьогодні пленарне засідання. Просимо до загального фото на сцені і також перед Палацом Академічний.
Дякую.
Просимо всіх швиденько підніматися на сцену для загального фото. Everybody is invited to the stage for the photo. Each participant and guest.
Любі друзі, які стоять під сценою, можна так от трішечки вбік, бо тут дуже багато людей, завалюється кадр. І ззаді масовка, також рівномірно, будь ласка, розподіліться на іншу сторону, у вас дуже багато справа. Я розумію, що місця мало, але давайте зробимо це гарно. Все, супер, давайте.
So much, and we have one more photo in front of the academic palace, just on the stairs. Перед академічним палацом, будь ласка, запрошуємо всіх ще до однієї фотографії швиденько. Будь ласка, виходимо на фотографію перед Палацом Академічний. Шановні учасники, запрошуємо вас до фотографії перед Палацом Академічний.